diagnostics and the immunohistochemistry validation for your laboratory is quite a robust stepwise approach as to how we can shore up our immunohistochemistry. And really, it's a continued process. Every time new markers come on board, when there's new batches, when there's changes to equipment, it's worth running through this checklist and just being confident in your immunohistochemistry. So back to our case report. So there are 3 differentials of a GI primary with some neuroendocrine differentiation, a standalone neuroendocrine tumour, or metastatic breast carcinoma. So all of these obviously would have a very different outcome for this lady, depending on which we decide to call it. So those of the more astute earlier from the chest x-ray may have noticed this lady only had 1 breast shadow. So what was hidden was that she had had a previous mastectomy for breast carcinoma. And this was performed outside of the country. So although we have a very helpful electronic care record here in Northern Ireland, which holds all of our patients' bloods, imaging and clinic letters, this lady had previously lived outside of Northern Ireland, and so this wasn't actually seen by us, and clinicians didn't think to mention that she had a history of a breast carcinoma, of course, as they often fail to tell you something important like that. But the pickup then of the chest x-ray, and we asked the question, is there a history of breast surgery here? And then it came out that this lady had had a grade 3 infiltrating duct carcinoma 5 years previously, and that was stage PT2N1, so she had node positive disease. And we requested those slides then from the hospital where it was performed, and there was some focal areas where there was a papillary growth pattern in that tumour. So we set the 2 tumours then side by side and realised that morphologically they were quite similar. And we also carried out synaptophysin immunohistochemistry on her tumour block from the breast cancer and found that it actually was also positive with synaptophysin. So this then unified the whole story for us. So this was her breast carcinoma. Hopefully you can pick out here the sort of palisade almost, and the vague rosette formation that we've seen in the colonic tumour also. Maybe a little bit more pleomorphic than what we had in the colon, but obviously the breast carcinoma was a bit larger and a bit longer to grow and become a little bit more pleomorphic, but not dissimilar at all than what we've seen. And this was her synaptophysin again, so I apologise for this picture. This is a horrendous photograph of the light microscopy image, but you can take my word for the tumour morphology, but the synaptophysin here obviously strongly positive. So what do we know about synaptophysin then in breast carcinomas? So a subset of breast carcinomas with papillary morphology such as this one do exhibit some synaptophysin positivity and have some neuroendocrine differentiation. By comparison then, if this lady had had a colon neuroendocrine tumour, they are in fact quite rare and only make up about 10% of the gastrointestinal neuroendocrine tumours that we see. The vast majority of them are small bowel or gastric, but I think most of us would say in our general work we see more small bowel neuroendocrine tumours possibly than anywhere else. If this had been a colonic neuroendocrine tumour, they typically come about quite late, and patients already have metastatic disease. But like ours, they do frequently turn up just as little incidental polyps. So during bowel screening procedures, colonoscopies for other reasons, you often pick them up as polyps sent in by our endoscopy teams. So in conclusion then, we decided that this colonic lesion was indeed a metastasis from the previously diagnosed breast cancer, and by default then both the omental metastasis and pulmonary nodules that were seen were also felt to be malignant by our radiology team. And so this lady was unfortunately put onto a sort of palliative care pathway. She had disseminated malignancy with no option really for curative intent. She had already had chemotherapy and radiotherapy at the time of her breast diagnosis, and so her options were a little limited now. Metastatic breast carcinoma, not uncommon. Most frequently probably picked up in endometrial polyps, especially patients who have had tamoxifen, sort of estrogen-driven growth there. But on my literature review on writing up this case, colonic lesions do appear to be much less frequent, and typically lobular carcinomas, of course, are famous for disseminated malignancy, and they seem to appear more commonly in weird and wonderful places. So what can we take away then from today? So morphology, obviously, still very important, and without morphology and having some clues as to where we might be going with our primary site, it's very hard to come up with a good immunohistochemical panel. So I think the morphology should always guide us first. So in this instance, the tumour site, the bland morphology, and that synaptophysin positivity, very easily you could have been led astray and called this a neuroendocrine tumour. So the clinical history really is of paramount importance, and finding out about history, I mean, we're all taught that as medical students right from the off. You know, the answer is almost always in the patient history if you can just get them to tell you the right information. However, in tumours with a little bit of papillary architecture, do think about metastatic breast carcinoma. This lady had a previous diagnosis, but of course, this could well have been a presenting pathology in this, equally as likely. So it's worth remembering that. And also immunohistochemistry needs to be robust and reliable so that we can be as accurate with our diagnoses as possible. So takeaway points then. Just a little interesting presentation of metastatic breast carcinoma occurring as a colonic polyp. But I think the bigger message to take from this, always keep your mind open when you see something that doesn't quite ring true. So the markers that this little polyp we're staining up with didn't quite sit with a neuroendocrine tumour, and it was worth digging deeper. But also, I think the most important thing to learn is that we have to have faith in our immunohistochemistry, and very little change in a panel can make a big difference. Some examples I personally have encountered of late where the diagnosis is really hinged on just one marker, perhaps things like sarcomatoid mesothelioma, often may only stain with one of the mesothelial markers, and so it can be very easy to think it's negative for mesothelioma. Equally, sarcomatoid carcinoma, again, you may only have one positive cytokeratin and discount the idea of a carcinoma, or indeed spindle cell melanoma or desmoplastic melanoma may only stain positively with a single marker. And again, it can be very bland, of course, morphologically as well, and it can be easy to discount a diagnosis of melanoma. And all of these obviously are time critical diagnoses to make. And as I said earlier, we are all expected to perform more and more diagnostic tests on smaller and smaller volumes of tissue, while also having in our mind that we need to perhaps retain tissue for molecular analysis or biomarkers which have drug targets. So we're trying to do as much as we can with as little tissue and keep what we have, especially in times of COVID, where we are perhaps seeing more patients who have disseminated malignancy, and this is our only chance perhaps to make a diagnosis for them. So robust validation of immunohistochemistry and validation, I think, are imperative for us, especially today. So you probably won't be able to read that, but if there's any of the references or a copy of the presentation or the paper from the best practice paper on validation that you'd like to go over with me, or you'd like a copy of, by all means, just get in touch. And all in all, thank you very much for your time. It's been a pleasure to speak to you this morning.
Thank you, Dr. Kelly. That was an extremely informative presentation to remind us that we must always consider history first, especially in lesions which look innocuous to the eye or which don't really fit in the current situation. Your points about immunohistochemistry validation also are excellent. I hope to all those listening, if you have any queries or questions about this presentation or about the topic, kindly get in touch with the organizers or with Dr. Kelly, and I'm sure they will be solved or answered as soon as possible. The same for Dr. Andreas's presentation. If anyone has any queries with regards to the cytology, I would request you to get in touch with the organizers, and they will forward it to him to answer them as per his convenience. Before our next speaker, we would like to take a short break. Our next speaker is Ms. Jayanti Jha from India. Her presentation is in the next 30 minutes. The organizers will get back to you shortly. Yes. Ms. Jayanti, welcome to the EPUCG conference. Thank you so much for joining us.
Thank you, ma'am.
Please go ahead. Please go ahead with your presentation. We're looking forward to it. Thank you.
Okay, ma'am. Yeah, so hello everyone. I am Jayanti Jha and I'm a second year PhD scholar from AIMS, India. I'm doing PhD in ocular pathology. So the topic of my presentation is role of pigmentation marker in uveal melanoma and its association with clinico-pathological parameters. So uveal melanoma, it is most common in intraocular malignancy in adults, and it involves uveal layer of the eye, majorly choroidal layer. So this is the gross diagram of uveal melanoma, and this is the choroidal melanoma. And it can be also rarely seen in ciliary body as well as iris. So tumor basically arises from the melanocytes that is present in the uveal layer and provides color to the eye. Some of the major symptoms include decreased visions, flashes, floaters, etc. So with an estimated worldwide 7095 cases, Asia and Africa contributes the least, that is around 0.2 to 0.4 million, that is 1600 cases per year. Whereas in white Americans, the incidence rate is around 6.02 per million. The mean age of their presentation is around 45 to 80 years, and their median survival is 5 to 6 months. Metastasis mainly occur in liver and can be also seen in lungs, skin, or bone. So there are many treatments which are there for uveal melanoma. First is transpapillary thermotherapy, in which infrared laser is used and it is pointed towards the tumor site and which causes tumor necrosis. Or there is brachytherapy, where radioactive seeds are used as plaque, and through radiation the tumor can be killed. Then there is laser photocoagulation, in which laser beam is used to burn the tumor. All these treatments are used when we can save the visibility of the eye, but when the condition is severe, then the ultimate option is enucleation, that is, eyeball is completely operated out. So uveal melanoma histopathologically can be classified on the basis of cell type, that is spindle, epithelioid, and mixed. Spindle cell type having with long cell and less prominent nucleolus, and it shows good prognosis. But in epithelioid cell type, there is abundance of cytoplasm and most prominent nuclei, and it shows worse prognosis. In mixed cell type, both spindle and epithelioid cell type can be seen, and if it is not treated early, then mixed cell type also result in worse prognosis of the patient. So there are major clinical as well as pathological high risk factors associated with uveal melanoma. So some clinical factors are tumor height more than 8 mm, detachment of retina, decreased vision, advanced tumor staging, LTD more than 15 mm, as well as iris neovascularization. And these are some pathological high risk factors, that is epithelioid cell type, ciliary body or scleral invasion, extraocular invasion, presence of mitotic figure or infiltrating lymphocytes, as well as tumor associated macrophages, pigmentation, and LTD. So in this presentation, I'm considered about the pigmentation as the high risk factor in uveal melanoma. So as we all know that as the pigmentation increases, cancer risk decreases. That is African and Asian have least cancer risk as compared to Britishers because of the presence of melanin in Asian or African population. In Asian population, there is the eumelanin is very prominent, that is dark in color, and in white population, pheomelanin is prominent, that is lighter in color. In this study, we are studying about the Asian population, so our focus is on eumelanin. So this is the fact which we are aware that as the pigmentation increases, cancer risk decreases. But there are studies which show that there is the aggressive role of pigmentation as well. That is, hyperpigmentation can produce many immunosuppressive, mutagenic, and reactive intermediates that results in the increase in tumor growth. Melanin act as the scavengers of oxygen. So as a result of hyperpigmentation, it contributes to hypoxia as well, which is also responsible for tumor growth. And all these make melanoma cells more aggressive, which becomes resistant to chemotherapy as well as radiotherapy. Literature also shows that the decreased melanin synthesis is less in advanced melanomas as compared to as compared to advanced melanomas. Increased pigmentation is also associated with distant metastasis, which has been seen in cutaneous melanomas. So we can say that pigmentation can act as a double-edged sword. So why are we studying pigmentation? Because according to literature, it is associated with hypoxia as well as necrosis, large tumor size, epithelioid cell type, inflammation, as well as metastasis. So coming to the point that melanogenesis. So production of melanin pigment is called as melanogenesis. This is the diagram of melanocyte, which consists melanosomes and having melanin granules, which buds off the melanin pigment from the dendrites. It is widely distributed in skin, hair, as well as uveal layer of the eye. And this melanin is responsible for pigmentation, which is an effective absorbent of UV radiation and protects us from cancer. So this is the melanogenesis pathway. This is a complete melanocyte, and through various hormone like melanocyte stimulating hormone, there is the initiation of signaling pathway, and which activates the transcription factor, which ultimately goes inside the nucleus of melanocyte and activates different genes responsible for pigmentation. These genes like TRP1, PMEL, they are transported to melanosome and initiate the melanogenesis pathway. So this is the melanogenesis pathway inside melanosome. So it starts from the L-tyrosine, and tyrosinase, which is the initiator enzyme, it initiates the pathway, and it can result into the synthesis of eumelanin and in pheomelanin. So in this eumelanin, which is present in Asian population, various enzymes are required like TRP2, TRP1, SILF, In this presentation, I'm going to talk about tryptophan and as well as hypoxia, as melanin is also associated with hypoxia. So earlier in uveal melanoma, some studies have been done. That is, it is in literature, it is there that pigmentation does not act as a protective mechanism, but it could act as a risk factor in the development of uveal melanoma, which was seen in white population. And few studies are also available which shows that pigmentation might be associated with the worst prognosis of uveal melanoma, but there is no studies in Asian population found in literature. So tryptophan, it is known as tyrosinase related protein 1, which is present in membrane of melanosomes and is responsible for the production of melanin quality. It is a key enzyme in the pathway of melanin synthesis, and it is synthesized in greatest abundance, and it also regulates the tyrosinase activity, which is the initiator enzyme of melanogenesis pathway and also is a rate limiting enzyme. So there is one study available which shows high expression of tryptophan in uveal melanoma cell line, but studies has not been done in patient samples. So as I have earlier told you that I'm also going to talk about hypoxia marker, as melanocytes, they decrease the concentration of oxygen as they are scavengers of oxygen, and they create the hypoxic condition, which results in tumor growth. So HIF1 alpha is one of those factors which regulates the tumor microenvironment in presence of low oxygen tension. So it has been its expression has been seen in many cancers, including uveal melanoma, but its importance with pigmentation has not been studied. So our aim is to detect the expression of tryptophan in association with HIF1 alpha in high as well as low pigmented uveal melanoma, and then their correlation with patient outcome. So this study is a prospective study where we have recruited 61 enucleated fresh tissue of 61 enucleated uveal melanoma sample, and 10 normal choroid was taken as positive control. And post chemotherapy and radiotherapy patients were excluded in this study. So we have collected, this is material in 61 enucleated specimens were collected, out of which we have extracted RNA of only 50 samples, and then we did real-time PCR for both the genes tryptophan and HIF1 alpha, and all 61 tissues were also formalin fixed, which were used for immunohistochemistry, and then their cytoplasmic staining was analyzed. More than 50% was given positive staining, and less than or equal to 50% was given negative staining. Then we have collected patient details, their demographic, clinical data, their histopathological high risk factors were analyzed, and their follow-up was done for 6 to 48 months. Then in statistical analysis, we have done chi-square tests to compare tryptophan and HIF1 expression with clinico-pathological parameters, and we did Kaplan-Meier survival analysis also. So this is the demographic detail of uveal melanoma patients. So there was male preponderance in our study, and 72% patients were above age of 40 years, and 43% patients have advanced clinical staging. 7 patients developed metastasis, out of which one was dead during follow-up. So 75% patients showed high pigmentation, and 36% showed epithelioid cell type. Scleral iris or ciliary body and optic nerve invasion was also seen in patients. High power field. And necrosis was present in around 30% patients. Lymphocytes were seen in 26% patients. So this is the tryptophan expression in in skin, which was taken as a positive control, and this is the low pigmented case where there is very less expression, that is almost around 10%, and this is the high pigmented case where we can see tryptophan expression very clearly. So similar result was obtained when we did immunohistochemistry for HIF1 alpha. So this is RPE, retinal pigment epithelium cell, which was taken as positive control. And again, there is very less stain in the low pigmented uveal melanoma case compared to high pigmented UM case. So then we have correlated TRP1 and HIV1, both the proteins, with clinico-pathological parameters. So out of 61, 37 patients showed TRP1 expression and 27 patients showed HIV1 alpha expression. So expression of both the proteins were positively correlated with high pigmentation, mitotic count more than 4 per 40 HPF, and as well as with BAP1 loss. So BAP1 is the known marker for uveal melanoma. So both the proteins were positively associated with the loss of BAP1. And TRP1 expression was also associated with high LTD as well as advanced tumor staging. And HIV1 alpha was also associated with necrosis and metastasis as well. Then we also checked mRNA expression of both the genes. So there was, compared to normal uveal tissue, in UM tissue, there was 6-fold increased in TRP1 expression and around 4-fold increased in the HIV1 alpha expression. Then again, for mRNA expression also, we have correlated it with clinico-pathological parameters. So RNA was extracted from 50 patients out of 61. So out of 50 patients, 30 patients showed positive TRP1 mRNA expression and 30% patients showed positive HIV1 alpha mRNA expression. Both were again correlated with high pigmentation and BAP1 loss. HIV1 alpha mRNA expression was also well correlated with high tumor staging. Then we did Kaplan-Meier analysis. We didn't get positive correlation with HIV1 alpha, but with TRP1 alpha, the survival analysis was correlated. So to conclude, the high expression of both TRP1 and HIV1 alpha was more common in patients with histopathological high-risk factors like high pigmentation and necrosis. High pigmentation might affect the tumor microenvironment, which could result in tumorigenesis. So TRP1 may be a potential biomarker likely to have a therapeutic value in uveal melanoma, but further studies are required in the larger cohort of patients with longer follow-up, and there is the need of translational validation. Thank you so much.
Thank you, Dr. Jayanti. Very informative and well-researched presentation. I would like to ask any of the participants if they would like to ask any questions to Ms. Jayanti. Kindly ask it now, or you can even post them in the chat group. Thank you.
Thank you so much, ma'am.
Please remember that at the end of the session, we will also have a short break in which any questions regarding to Dr. Andreas, Dr. Kelly, or Ms. Jayanti's presentation can be asked in the forum, and we will get the speakers to reply to your questions as soon as possible. Please stay logged in during the break as well. I would now like to call upon our next keynote speaker, Dr. Cazzato Gerardo from Italy. Dr. Cazzato, please proceed. Thank you.
Thank you very much. Good morning, everyone. I am Gerardo Cazzato, specialist since a month in pathology. For me, it's an honor to speak with you. My presentation will treat about a typical fibroxanthoma-like melanoma. That is a rare entity of melanoma. In abstract, a typical fibroxanthoma-like amelanotic melanoma is a very rare variant of melanoma that can, if not correctly recognized and framed, lead to diagnostic error that can potentially cause a problem of extreme relevance to patient. A correct knowledge of this entity and the execution of adequate immunohistochemical panel are the basic condition for a correct management of this lesion. We, therefore, report a case of a typical fibroxanthoma-like melanoma, which clinically simulated a fibrohistiocytic lesion and which created, for pathologists and for dermatologists, differential diagnostic problems. And finally, we conduct a very short review of the current literature. In introduction, a typical fibroxanthoma-like amelanotic melanoma is described in English literature for 4 or 5 cases. Therefore, is a very rare form of melanoma, and the correct knowledge is of fundamental importance because many problems in terms of differential diagnostic can be created. Yes. In particular, this melanoma can mimic many skin cancer and benign skin lesion, and its correct diagnosis is of fundamental importance for the nosographic classification of the lesion. Case history. A 93-year-old man came to the University Dermatology and Venerology department following the identification of a lesion to the right auricle of approximately 1 centimeter in diameter that had been present for about 2 years. The lesion had been interpreted by the dermatologist as a fibrohistiocytic tumor without suspicion dermoscopical appearance. The lesion was excised, formally fixed, and sent to the University Pathological Anatomy department. After sampling and paraffin embedding, some histological sections were routinely stained with hematoxylin eosine. The lesion was centered in the dermis, ulcerated, and made up of spindle cell with pleomorphic, hyperchromatic, and sometimes nucleolated nucleus, moderate to high eosinophilic cytoplasm, and arranged in fascicular, sometimes randomly fashion. There were also giant multinucleated Teuton-like cells, like a typical fibroxanthoma, especially in the superficial part of the lesion. But at higher magnification, several mitotic figures were observed of both typical and atypical nature, and there were outbreaks of peritumoral inflammatory lymphocytic infiltration. Phenomena such as necrosis, hair hole, and hemorrhage were not evident. The dermo-epidermal junction did not present any junctional melanocytic growth, and there were no significant alterations. On the other hand, the lesion was noted to make contact with the nerves surrounding them, arrows. The morphological characteristics were coherent with the diagnosis of a fibrohistiocytic lesion of a typical fibroxanthoma type family. However, some immunohistochemical tests were carried out in order to confirm this clinical and pathological diagnosis. The immunohistochemical tests were negative for CD10, positive in many atypical fibroxanthoma, together with the vimentin, CD68, CD34, and 31. Immunostaining for SOX10 and C100 protein were strongly positive, including in Teuton-like cell, while the reaction for melana and HMB45 were negative. Immunohistochemical, this is S100 protein. Immunohistochemical tests for P14 and P63 resulted negative, and they were also carried out in order to exclude the possibility of a pseudosarcomatous squamous cell carcinoma. According to the immunohistochemical profile, the hypothesis of melanocytic lesion was suggested, and the specimens were re-evaluated in the light of this new hypothesis. Some positive mast cell, CD170 and tryptase, as well as some small nerves deep down in the lesion, were identified. Therefore, the diagnosis of neurotropic melanoma with diffuse phenomenon of desmoplasia was made. Discussion. Melanoma is one of the most aggressive malignancies. Its correct identification and consequent diagnosis is of fundamental importance in order to correct manage the patient. Melanoma can mimic many different tumors, such as dermatofibrosarcoma protuberans, or malignant fibrocystocytoma, or myxofibrosarcoma, malignant hemangiopericytoma, and malignant schwannoma, which leads to many problems for the pathologist. In particular, we describe a case of a very rare variant of melanoma with morphological characteristics similar to atypical fibroxanthoma. This variant has very rarely been described in literature, with only 5 cases found in research published on PubMed and Medline. More specifically, 5 cases by various authors have been described, all in elderly patients, more than 65 years, in parts of the body exposed to sunlight, hand and neck, for example, and in at least 2 cases, just as in Hours, the clinical hypothesis did not take into account the possibility of melanoma. Comparing our case to those reported in literature, in 2 cases, the immunohistochemical markers S100 protein, melanine, and HMB45 came out completely negative, making the diagnosis even more difficult. Our case presented high positivity for SOX10 and S100 protein, which allowed us to come very easily to the hypothesis of a melanocytic lesion. Another very important aspect consists in the fact that the lesion in our case had a large maturation, making it impossible to identify an area of melanocytic junction proliferation that would have helped the diagnosis of melanoma, also using hematocileusin. The diagnostic clue in our case was the finding of some small deeply embedded nerve and the presence of a few mast cells that are characteristic of neurotropic/desmoplastic melanoma. Also, morphologically, the lesion mimicked an atypical fibroxanthoma. Negativity for CD10, CD68, and vimentin was not in agreement with such a diagnosis, and the simultaneous negative result for melanine and HMB45 made the diagnosis even harder, making a potential different diagnosis between primitive or metastatic lesion was practically impossible, insofar as the absence of melanocytic junctional proliferation did not allow us to be certain the primitivity of the tumor. Even through imaging examination, such as RMI, did not reveal tumor in other areas of the body. Finally, we have described the 6 rare cases of atypical fibroxanthoma like a melanotic malignant melanoma, which is a very rare entity that can be difficult to diagnose. Correct immunohistochemical testing, together with the knowledge of the existence of such a variant, is of fundamental importance so as to correctly identify the lesion, hence avoiding incorrect diagnosis. Thank you very much. This is images, my images. Saluti da Bari.
Very thanks from Bari.
Esatto. And for collaboration, there are a Facebook page, Instagram page, and my email. Thank you very much. See you soon.
Thank you very much, Dr. Gerardo. That was a very interesting case. I think after bringing it to our notice, I am sure the histopathologists are going to look for more and more of these lesions. We do know that melanoma is one of the greatest mimickers ever known and can mimic a vast spectrum of soft tissue as well as epithelial appearances. With that in mind, thank you very much for a very informative and rare case. And I would now like to call upon our next speaker, Dr. Neethu Vanapalli from India. Dr. Neethu, please take the stage. Thank you.
Yes, good afternoon, everybody. I'm here to present a topic on spleen, and let me share my presentation in the meanwhile. Yes. Can you people see my presentation?
Yes, it's visible. I think
visible.
now we can just see the screen. Yes, it's visible
yes,
now.
Please,
yes,
it's visible. Okay. Okay, so let me give a quick briefing on the topic that I'm going to be presenting. Splenectomy specimens are taken into our study for this research work that we are going to present. And the splenectomies are done in all the whatever cases that are leading due to portal hypertension at Apollo Institute of Medical Sciences in southern India. So the contents, let me go through the quick contents. That is introduction, aims and objectives, materials and methods, results and conclusion. So that being said, let me start off with the introduction. Spleen being considered as an organ of mystery by Galen is as true as gospel. So because spleen is an organ of mystery and it holds many clues to whatever is going on systematically in the body, and indications for therapeutic splenectomy are hematological and cystic conditions, abscesses, infiltrative diseases, splenic rupture, and neoplasm. So the first ever splenectomy, let me give a quick glimpse on the history aspects of the splenectomy. The first ever splenectomy specimen was performed in Italy way back in 1549 by Zaccarello, which was later followed by Quittenbaum, who did elective splenectomy for portal hypertension in 1826. There were various studies and research papers published so far which have emphasized on diagnostic splenectomies and their diagnostic abilities. However, splenectomy may be a helpful tool in therapeutic indications as well. So my study mainly emphasizes on the indications of therapeutic splenectomy and its uses in today's day. So moving on to the next slide, the normal weight of spleen. So let's just give a quick brushing through what is the normal in spleen. The weight of spleen normally is considered as 70 to 200 grams, plus or minus 100 grams. Splenomegaly, what is it? It is the weight of spleen when it is beyond 400 grams, usually. So, but in our institute, we have considered it as anything beyond the normal weight. Splenomegaly, based on the weight, is again classified into mild, moderate, and massive splenomegaly. Massive splenomegaly is hardly seen in most of the institutes, and massive splenomegaly is prominent in those countries where there is Kala Azar. So mild splenomegaly and moderate splenomegaly is what we have also included in our study for today. Splenomegaly is based on the pathophysiological mechanism, which is again classified into 4 types according to the literature existing. That is, starts with congestive splenomegaly, infiltrative splenomegaly, immune splenomegaly, and neoplastic splenomegaly. So we have 4 variants of splenomegaly based on the pathophysiological mechanisms. In the existing literature, the splenic pathology was assessed based on examination of red pulp and white pulp. Cystic lesions for diagnosis in spleen can be another daunting task on imaging, as the nature of splenic cysts is not known till the histological diagnosis is made. So, I have done some research to find out how much of diagnostic splenectomies is useful for the clinicians and for the patient point of view. The diagnostic ability of the splenectomy was 46% in a study conducted by Patrick et al. They also emphasized that splenectomy may be a useful diagnostic and therapeutic tool in select unknown diagnosis and hematological malignancies like chronic myeloid leukemias. So as we should know the location of the spleen in the abdomen, it is not protected by the bony cage, which makes it more prone to traumas and traumatic injuries. So the materials and methods that we have used for this study, it is a retrospective analysis of the splenectomies received by Department of Pathology, Apollo Institute of Medical Sciences and Research at Hyderabad in India. It is a 2-year study period conducted from October 2018 to October 2020, which includes most of the corona time, pandemic time. The tissue specimens were subjected to standard macroscopic and histologic examinations. 12 splenectomies were examined microscopically after detailed grossing, followed by processing and routine hematoxylin and eosin staining. The data regarding age, gender, and clinical details were collected. Results: the most common splenectomy had shown that the most common splenic lesion was indicated for congestive splenomegaly, that is 25% in most of the cases, followed by splenic rupture that due to trauma, that is 25% again, and epithelial cyst, which is 16%. I have given the major components only. You can later check on the pie chart where the minor components are also comprising. The ages of the patient ranged from the age of 24 till 52 years for the splenectomies. And there was a female preponderance that is 2 times higher than the males. Histopathological spectrum distribution, as you can see in this pie chart, there is the maximum component, which is congestive splenomegaly, is a main indication for the splenectomies conducted, followed by splenic rupture, which is 25% again. And then we have the epithelial cyst, which is primary or true epithelial cyst, that is making it 17%. And then followed by keratinous cyst, epidermal type, 8%, reactive follicular hyperplasia, 8% again, and extramedullary hematopoiesis, which is 8%. Also, not to forget the abscess component, which is making it of 9%. So also, if we look at the cystic lesions of the spleen, the cystic lesions of spleen is again divided into 2 components. That is the primary epithelial cyst, which is 17%, which is more common than the keratinous cyst of epidermal type in our study. According to the study conducted by Sarangatham et al., highest cases belong to the non-neoplastic group, which comprised of 90% of their cases. And the neoplastic group was 11% only in their study. The age group that most of the patients belonged in their study were in the range of 21 to 30 years in their study. Yes. So quickly moving on to the next slide. It was observed that portal hypertension was a major contribution of splenomegaly in the clinical diagnosis. The majority of splenomegaly belong to the moderate splenomegaly category, followed by mild splenomegaly and normal spleen weight, that is only in 2 cases. So which says that we did not have any case of massive splenomegaly in our study of 12 cases. So this is a distribution pattern of the splenic weight in the across the 12 cases. You can see that the maximum weight of the spleen was taken by the case number 6, which had almost reached till 1,000 grams, but not crossed it. So it falls in the moderate splenomegaly category. And now, looking at the photomicrographs of the histopathology pictures of the red and white pulp. As we look into the first photograph, here I had captured a Gamma-Gandhi body, which is a rust-colored foci that you can see. It is made up of the fibrous tissue, hemosiderin, and calcium. This is stained by hematoxylin and eosin. It is seen on the low part. In the next figure, you can see the white pulp photograph where the lymphoid follicles are seen of various sizes with germinal centers, which means these are all reactive. It is captured, this photograph was captured on a scanner view by hematoxylin eosin staining done. The following figure shows a epithelial line cyst, which is lined by the flattened to cuboidal epithelium on medium magnification. Again, 10 par view this is. So we can see the lining cyst here, the flattened lining cyst of the splenic tissue. In the next figure, we can see that there is an abscess of the spleen showing, indicating extensive areas of hemorrhage with neutrophil exudate along with lymphoplasmocytic infiltrates on scanner view. Yes, the next figure shows a congestive red pulp, which are comprised of dilated sinusoids and the thick-walled sinusoidal nature that is seen in this photograph. And there is also a lot of inflammatory cell component surrounding the sinusoidal tissue. This photograph is taken on a scanner view. The following figure shows the gross photo of the cystic lesion of the spleen. The solid content of the spleen is replaced with the cystic lesion, uniloculated, inner surface being smooth. So this is a table showing the recordings of the dimensions of the splenectomies received. And the maximum dimension is taken by case number 6, that is 19.5 by 15.5 into 5.5 centimeter, the maximum dimension. So the largest spleen that is. And the next figure, figure 8, showing us the distribution of splenomegaly in splenectomies, which showed that moderate splenomegaly comprised of 50% of our cases, followed by mild splenomegaly of 33% and normal being 17%. Massive splenomegaly had comprised only 0%. We did not have any cases in this category. Moving on to the conclusion part. So through this study, the histomorphologic evaluation based on the grossing and microscopic parameters have been recorded, and also found that the red and white pulp evaluation is pivotal in understanding the splenic pathology, just like in the existing literature. Elective splenectomy, when done timely, has influenced and improved the life course of the patients postoperatively, though splenectomies once done can increase the chances of infection in such patients by capsulated organisms, but even then, the chances hold as good as patients getting suffered with traumas at home. So that is worth taking the risk, and performing an elective splenectomy will only relieve the patient from such symptoms, that is like pain, mild pain, dull aching pain in the quadrant. So these are my references. And I hope I have covered most of the topics related to the spleen, entailed in the spleen chapter. And also a point to add on is the most common indications in the research when I have done, the most common indications for therapeutic splenectomy was portal hypertension along with splenomegaly, and abdominal discomfort was observed as a common physical symptom. And the majority of the pathophysiological mechanisms behind splenomegaly in the limited study, as ours, was congestive etiology. And so that being said, I would like to thank the organizers for giving me an opportunity to present our little limited study conducted at Apollo Institute of Medical Sciences, Hyderabad, India. Thank you.
Thank you, Dr. Neetu. It was a very well-researched study with an exhaustive array of the splenectomy specimens. I think for all of us, it is interesting to note that any splenectomy specimens by weight and by histological examination can give us a lot of clues as to the disease process occurring in the patient. So a very well presented case study. Thank you so much. I would like to call upon our next speaker, Dr. Galia Settikova from Russia. Thank you so much for joining us, Dr. Galia. Please take the stage. Thank you.
Thank you so much. Good afternoon, everyone. My name is Galia Settikova. I'm a pathologist from Moscow, Russia. Today I would like to tell you about abnormalities of the duct system of the pancreas associated with ampullary cancer. As you can see on this slide, there are 4 parts of my presentation. In the beginning of my presentation, I will remind you gross anatomy of the pancreas. The pancreas is a recent ruberiform with a lobulation. There are head, neck, body, and tail. The pancreas is not an encapsulated organ. The duct system including main pancreatic duct and common bile duct. Pancreatic duct system structures identified prior discovery of physiological secretory function. Understanding duct anatomy of the pancreas described Wirsung in 1642 years. The main pancreatic duct of drainage of pancreatic saccharine secretion begins in the tail of the pancreas by a confluence of smaller ducts from acini. The main pancreatic duct is located inside the pancreas and has an almost perpendicular path of the duodenum wall. The depth of the main pancreatic duct from the upper surface of the pancreas varies from 2.5 to 3.0 centimeter. The duct can form as S-shaped, first to the upper posterior surface of the pancreas, then to the lower posterior, and only then flows into the papilla of duodenum. The common bile duct is formed by the fusion of the cystic duct with common hepatic duct. Both common bile duct and main pancreatic duct are formed the ampulla of water. Santorini duct isn't a minor papilla. There are 3 anatomic variations in the relationship between common bile duct and main pancreatic duct. The first, white type, confluence of common bile and main pancreatic ducts with a common channel of 3 mm or more. The second variation, V-type, confluence of common bile and main pancreatic duct of 2 mm or less. And 3-type or U-type, then common bile duct and main pancreatic duct are separated by a septum, each duct having a separate outlet into the duodenum. The second, we talk about abnormalities of the duct system. The abnormality of pancreas is very, very rare, about only 1%. Pancreas divisum is the most common variation of pancreatic formation and may be present up to 10% of the general population. What means pancreas divisum? The term describes the anatomic variation of the pancreatic duct system in which the dorsal and ventral pancreata fail fuse during embryology development. From 5 to 8 weeks of embryogenesis, the duodenum acquires a C shape, the ventral bud and dorsal bud and single duct system is formed. First description of pancreas divisum in human is a graph in 1664, but quantum pancreas divisum is Michael in 1812. In normal, the duct system or the ventral bud Wirsung or main pancreatic duct and dorsal bud accessory pancreatic or Santorini duct fuse together to form the main pancreatic duct that opens at the main papilla along with a common bile duct. There are 3 types of pancreas divisum described. The first, complete or classic pancreas divisum, the ventral duct system is short and opens into the myopapilla of all common bile duct, while the longer Santorini duct system opens into the minor papilla. This type prevalence up to 70%. The second, incomplete pancreas divisum. A singular anatomy of the classic pancreas duct, except for a small branch of communication between the two systems. The prevalence of this variant about 15%. And third, reverse pancreas divisum. This is a rare variant where in the accessory duct of Santorini doesn't communication with main pancreatic duct. Pancreas divisum increasingly identified by ERCP since 1917. And then we talk about what means ampullary cancer. In the last version WHO classification of tumor 2019 Blue Book, ampullary cancer is a malignant epithelial tumor of the small bowel with epicenter in the ampulla. In ampulla area, there are 3 types epithelia. Pancreatic and the common bile duct are linked with PB or pancreatobiliary type of epithelia. The papilla is covered intestinal type of epithelium. There is also the third type of epithelia, as known as hybrid or mixed type, which is formed by fusion of 2 PB and intestinal type. Up to 50% of Whipple resections are performed for ampullary cancer. About 10% of all periampullary cancer. And men are affected singly more than women, age range from 30 up to 80, with median 60 age. Patients with ampullary cancer present in a manner similar to those with pancreatic cancer. Most patients' primary complaint is a jaundice. The gross appearance of this cancer is dependent on the portion of the ampulla from which they derive. Periampullary cancer, the biggest tumor that are readily even upon opening the duodenum and inspecting this region. This type up to 80%. intraluminary cancer, the smaller tumors this group were characterized by a prominent intraluminal growth of pre-invasive neoplasm, the ampulla. Most ampullary cancer are adenocarcinomas, but the histology varies, with the tumors comprising subtypes included papillary, mucinous, and adenosquamous types. Ampullary carcinomas classify in two main immunophenotypes. The first one is PB type, which expressed MAC1, MAC5, and CK7, and second one, intestinal type, which expressed MAC2 and CK20. For ampullary cancer is more typical intestinal type, which found in 85%. Here, you see 5-year survival difference between ampullary and pancreatic cancer. It's quite drastic. And finally, of my presentation, we talk about anomalies. Of course, pancreas divisum was associated in ampullary cancer. The results of studies support the hypothesis that pancreas divisum contributes to or is a primary cause of pancreatitis. In the literature data, pancreas divisum associated with pancreas different disease. For example, pancreas cancer, exocrine cancer, neuroendocrine cancer, but small topics about associates pancreas divisum with ampullary cancer. Our aim to estimate the frequency of pancreas divisum in ampullary cancer and their relationship. 61 cases with ampullary cancer were evaluated since 2008 to 2015. Immunophenotype by IHC with MAC1, MAC5, and MAC2. In order to detect pancreas divisum is necessary a well-gross examination. Pancreatoduodenal complex included main component, duodenum, head of the pancreas, common bile duct, and Meyer papilla, and accessory component, minor papilla, pylorus, and gallbladder. The first step of dissection is orientation complex. With gastropancreaduodenal resection, the pylorus lays on top of the pancreas head and the free segment of the duodenum or ileum lies below. At pylorus prevented operation, the proximal end is always shorter and located above pancreas, pancreas of head. According to this orientation, the anterior surface is more convex and posterior surface is shallow. The second step of dissection, opening the duodenum and inspected this region. Then we need duct probing. This is a very important step since not only the patency of the ducts determinate, but also the location of the tumor and anomaly of the duct. This slide just shows the classic pancreas duct. This zoned in common bile duct, this zoned in Santorini duct, and after dissections, we was found a smaller main pancreatic Wirsung duct. And only then we open the pancreas along the ducts, common bile and main pancreatic ducts, to the anterior and posterior surface. As you can see on the slide, pathological data. Ampullary carcinoma is most cases low-grade cancer with no preneural invasion, most cases no metastasis in lymph node, and all cases are zero status. Pancreas divisum is frequent anomaly and detected in 17 cases. Type 1 was the complete pancreas divisum, was the most frequent 15 cases. And type 2, incomplete pancreas divisum, had a frequency only 2 cases. We didn't find a statistical relationship between pancreas divisum and pathological data. Also, we didn't find a statistical relationship between immunophenotype ampullary cancer and pancreas divisum. Of course, intestinal monophenotype is a more phenotype for ampullary cancer, and the pancreas divisum up to 67%. But if you compare the total percent of intestinal monophenotype and PB type, then you will not find differences. We decided comparing the frequency of pancreas divisum in ampullary and pancreatic cancer. We found a clear correlation, up to 6 times pancreas divisum in more common in ampullary cancer. Pancreas divisum is well visualized as at MRCP and ERCP. MRCP detects pancreas divisum with a similar occurrence as the invasive technique of ERCP. I will remind you my previous slide. It's very important data, especially for young patients, because pancreas divisum should be important to raise the suspicion of ampullary cancer in patient. In conclusion, pancreas divisum is not associated for the clinical data of patients with ampullary cancer, for example, sex, age, etc. Pancreas divisum is not associated with the pathological data of ampullary cancer, immunophenotype, tumor, PT tumor, PN, perineural invasion. Pancreas divisum is 6 times more common in ampullary cancer compared to pancreatic cancer. And the pancreas divisum should be important to raise the suspicion of ampullary cancer in patients. Thank you for your attention.
Thank you, Dr. Galia. A very well researched topic and excellent gross pictures of the dissection of the pancreas. I'm sure for many of the attendees, it's a very informative talk, and for them to realize how to gross the pancreas correctly, especially in Whipple's resection specimens. Thank you very much.
Thank you so much.
May I ask a question?
Yes,
Is it possible to pose a question? 2 questions, actually. So first of all, thank you very much for this very nice presentation. The part of the anatomy was really, really, really good. Only the thing that we cannot read the Russian, you know. It was all in Russian subtitles. But anyway, I have my company, Pathologica, is working extensively in early detection of pancreatic cancer, development of methods. So we are very much inside this subject. It's a really big issue, you know, that cancer, this type of cancers is really aggressive and with a lot of impact, lethal impact on the patients. Anyway, I have 2 questions. We studies and we see that most of the pancreatic cancer arise from the junction between the ducts and the glands. These cells differentiate whether or to the ducts or to the gland, and these are the prone cells that might become neoplastic. Now, the question is, if you focus on the ampulla, is it a real, can you define it as a real different feature compared with what you find in the rest of the organs? This is question number 1. Second question, there are a lot of papers now published on the configuration of the flora that of the gut in the gallbladder and also in the ampulla of the pancreas. Some assembling of these flora is related with pancreatic cancer. Do you have any data from your point of view regarding these first findings, scientific findings?
Thank you for your questions. We have no data about pancreas divisum in sorry, we have data about pancreas divisum with pancreatic cancer, exocrine cancer, and the total percent of pancreas, pancreas divisum, of course, smaller than I showing now, because in this talk we about only ampullary cancer.
Okay. It's not really answering my questions, but I understand that there are no answers. But anyway, thank you very, very much for this very nice presentation. It was really, yeah, very systematic, and yeah, thank you very much for that.
Thank you.
Thank you, Dr. Galia. Thank you, Dr. Emmanuel. Would you like to share with the audience if you have any experience with respect to the flora? So if there are any students and all listening, they would like to probably look into it, into their studies. Your experience in this?
Most of the papers are published in the gallbladder pathways regarding the flora, and there are already some types of bacterial population that when they are there, the chance of gallbladder carcinoma or gallbladder waste carcinoma is increasing. In the pancreas, it's just the beginning, so there are few references, but I think that this is a point to consider as a triggering.
As a trigger, and probably a point for therapeutic implication in the future as well.
Yeah.
Yeah, thank you so much. It's a request to everyone who's listening in. If you wish, please raise your hand. We will unmute you to answer questions. If you have any questions, you can post them in the chat forum, and we will address them to our speakers. I would like to remind you, our speakers were Dr. Kelly Elliott. Thank you so much, Dr. Kelly. Dr. Andreas Lupka. Thank you so much, Dr. Andreas. Ms. Jayanti Jha. Thank you so much, Ms. Jayanti. Dr. Cazzato Gerardo. Thank you, Dr. Gerardo, for your case. Dr. Neetu Vanapalli. Thank you, Dr. Neetu. And of course, Dr. Galia, who has just presented on the pancreas. Please feel free to post your questions. I'm sure that a lot of doubts or queries would have been raised during these talks, and we would be more than glad to deal with them by the speakers. Thank you so much.
Thank you.
I would like to pose one question to Dr. Andreas, if he is available.
Yes, please.
Yes, Dr. Andreas, I just wanted to know, in the COVID lockdown period for your cases with pleural effusions, these would also have included patients with positive COVID-19 antibodies or tests. Were there any special precautions that you all took while processing these specimens for cytology to prevent infection?
Oh, that's an excellent question. This covers one very interesting issue. When we had our COVID lockdown, the testing, of course, was quite sparse. But we have an electronic system that automatically labels the patient with a known COVID-19 infection. And as far as I know, this was my initial question to our data set. So I wanted to know how many patients with COVID-19 infection we had in the cytological specimen. And this was a very rare number. I think it was 2 or 3 patients with a known infection of COVID-19. Therefore, this was not a very relevant question. We only had a very, very few samples with COVID-19. But During this lockdown, we altered our laboratory procedures completely, and we raised all our security routines. So usually, even it's COVID-19 or not, our dealing with the specimens is very sensitive, and we've got a very high level of security because well, COVID-19 is just one of a lot of serious infections, for example, HIV, hepatitis, and very, very dangerous also tuberculosis. And therefore, the preparation of the cytology is a very, very safe method. And so we did not have to do anything about specimen preparation because our security level is very high. The danger comes more from the human resources. We had to separate our cytology teams. We made 2 completely independent teams that did not have contact to each other. But if we had some incidents of COVID at our technicians, for example, only half of our staff would fall out. And so the challenge was not the dealing with the specimens, but the challenge was to prevent any infection from the hospital and from your colleagues.
Okay. That's excellent information. I think the challenge lies in other laboratories which may not have as much advanced techniques for cytology separation and for retrieval. But I think the point raised is that to create a separate cytology team to deal with high risk and infective samples is very important. There is a question for Ms. Jayanti Jha. Please, Dr. Neetu, can you please post your question?
Yes. Is Jayanti Jha available?
Yeah.
Yes, please.
Yeah, my question. Yes, my question for you. Your presentation was well framed and well presented. I had a question though. What is the type of the procedure done for the uveal melanomas? Is it enucleation of the eye, or what is it? Like when the entire orbit has to be seen, the retinal layer has to be seen, the melanocytic pigmented epithelium. I wanted to know what is the procedure done because that was not mentioned. So yes.
So when the enucleated eyeball comes to our lab, so the pathologists who are there, they cut the eyeball from the center, and then from the center, the tumor in the uveal layer or near the ciliary body or near the iris, we take out from the scoop the tumor tissue, and then we used it for the RNA isolation or DNA isolation, whatever we want. And for when we have to do immunohistochemistry, then after cutting the layer, there are technicians there who cut the tissues into sections on the polylysin slides, and then we use that for IHC.
Okay. And then so the procedures is total enucleation of the eye on a morbid case you're talking about.
Yes, the enucleation comes from the operation theater to our lab only, and then the pathologists cut that eyeball.
What is the preservatives used for transfer of the orbit specimen?
Okay,
Is it
when it comes from OT, they keep it in saline, and then after saline, and then after isolating tissue, we put it in 10% formalin. Then after
10% formalin?
Then 48-hour after 48-hour fixation, we used it for sectioning and then IHC.
Okay, thank you so much, Jayanti Jha, for your patient answering.
Thank you, ma'am. Thank you.
Thank you, Ms. Jayanti, and thank you, Dr. Neetu, for an excellent question. We have 2 more questions in the forum. One is by Mr. Milas. Can you please ask your question to Dr. Andreas, please?
Hello, everyone. Do you hear me?
Yes, you're audible. Please proceed.
Thank you. I'm Dr. Milad Abdesalam Al-Nasri from Iraqi Ministry of Health. I have PhD in immuno and molecular genetics. I have a question to Dr. Lubik, please. don't you think, doctor, that the histochemistry preparations nowadays are so laborious and need so many expertise? And don't you think that molecular techniques are more reliable nowadays? This is my question, and thank you very much for allowing me to contribute in this impressive conference. Thank you very much.
So I will repeat the question so that I got it completely right. So you asked, isn't it better just to do the molecular analysis on the histology material? Is that right?
Yes, because it is laborious and needs so high techniques and a high expertise. Don't you think that? Thank you.
Yeah, well, very good question. And this is a very central topic of cytology. The basic question of our human beings is, why are we on Earth and why do we exist? This is a question every human has asked himself, including me. And so this is also a question for the cytologist. Basic question for the cytologist is, do we need cytologists?
Yes.
And
because I have a PhD in molecular genetics, so
yeah,
I have a bias to my specialty.
Yeah,
So
I know. So, but this is a very important question. If there is some histology material available, of course, we do the analysis on the histology because the procedures are more something like, not even more reliable, but the routine is based on this. And but it happens that sometimes your cytology material is your only material. Cytology samples can be harvested quite easily, and they can be analyzed quite easily. And I will answer the question with some separated comments. First of all, there are some cases where we only have cytology. Advanced cases, for example, with multimorbid and old patients, where you have to think whether you get another histology or not. For sometimes bronchial brushings or endoscopic biopsies can be a severe danger for the patient. And sometimes you get your cytology, and with advanced technicians and advanced preparations, you can get the whole predictive markers out of your cytology. I know this sounds a little bit weird because histology is the established method, but it's possible to perform all predictive markers if you have got enough cells in a cell block. So it's so regarding the predictive markers, it's completely equivalent, and especially with the molecular markers, because they work excellent on the cytoblock. The fish is marvelous, and the extraction of DNA for our NGS investigations are completely comparable. The next thing is that in cytology, you get quite a lot of cells. So in a bronchial biopsy, it's one challenge that you do not have enough material of the tumor to do all your molecular investigations. And usually when you get cytology, you have a lot more cells than in a small biopsy. So you can perform all the markers, and this can be an advantage. Third is
sorry, Doctor. Sorry, Dr. Lubeck. Sorry for interrupting you. Of course, all these branches are complementary to each other. I didn't mean to lessen of one branch and to. These branches are uncomparable, of course, but do you mean, or what I understood from you, that when we want to detect the tumor markers, is the best way is by histochemistry preparations better than to use molecular techniques. Am I right? Did I understand your reply right?
Well, no, it's completely equivalent. So because we can identify the cells, and the cell block is prepared like a paraffin block. It's also formalin fixed. It's also paraffin embedded, and comparative studies have proved that the results are equivalent. In particular, this goes down to the molecular level, because there's some difference between a fish of in paraffin and in a cell block. We count green and red dots, so it's completely similar. And the quality extraction of the cell block is also quite equivalent. The only issue may be immunohistochemical markers, but also when we go down, for example, to PD-L1, the results are completely comparable. The only thing where I do not recommend doing predictive markers in cytology is a direct immunocytochemistry on smears, because this is affected by drying artifacts and fixation artifacts. And I would not recommend doing PD-L1 on a smear, but all the other things are completely equivalent.
Thank you very much, Doctor. Thanks for your patience. Thank you.
Thank you, Dr. Andreas, and thank you, Dr. Millard, for an excellent question. We have another question for Dr. Andreas by Dr. Kelly on rapid on-site evaluation. Dr. Kelly, please proceed.
Hi, Andreas. I guess this really follows on from what we were just talking about in the previous question. We offer on-site examination for both our breast clinics and our EBIS respiratory clinics. The breast ones, we do actually core any malignant or equivocal looking lesions, and then we roll those cores so that we still have a direct smear on the day to feedback results from. At our EBIS clinic, then we make direct smears on site and try and make a diagnosis of malignancy, small cell, non-small cell, and if possible, then we put more tissue into formalin, as you said, to make a formalin fixed block then for confirmatory immuno and the molecular analysis. We've been trying to continue that service through COVID with the respiratory stuff, especially the breast, not so much, because at least everything can be cored and come to the lab the next day and we don't need to be on site at clinic. But with the respiratory EBIS list, we have continued to attend that as cytopathologists with all the respiratory precautions necessary for COVID. And I just wondered if you had any experience of that and the difficulties that it has posed with the extra PPE and the reduction in people available to man those lists and provide that service.
So this is a question concrete to the clinical management of the COVID of the EBIS patients in the COVID period, right?
Yeah, just as a cytopathologist, do you attend your own EBIS on site, or do you report them in slow time or in real time?
Oh, it depends on the clinic. And so we are a large university medical center, and pathology is now something like a service open to other clinics. So we do not serve our own clinics. So we've got about 15 to 20 smaller to intermediate size hospitals we serve as pathologists. So this is a very inhomogeneous situation. So, but I will give you three different groups. So we've got one very well-known hospital that does perform rapid on-site evaluation. Then we have some physicians who do the endoscopy, and they do the cytology basically by themselves to evaluate whether they harvested enough tumor cells. They can do this approximately by themselves, and sometimes a cytopathologist is on site to say, well, this is sufficient specimen. But this is a very special clinic, because this clinic is specialized on lung pathology, lung surgery, interstitial lung disease, and so on. So then we've got other clinics where they do FNA of the lung and EBIS, and they just do it blind, and they perform about 4 or 6 smears from a suspicious lesion. If a lesion is unsuspicious, they just do 1 or 2. And if it's a suspicious lesion, they perform 6, 4, or about that number. And it depends truly on the physician, because some clinicians have a very good rate of reaching the lesion. And the last group is a group of endoscopists who just do one FNA and just send the smear. So, and I also talked to this group. I said, well, would you like to improve our cytology methods? Would you like to have additional fixation things? Should we do some FNA smears together so you get to know and do it? And they said, no, well, if you can say tumor yes or no in about 5 to 10% of our specimen, we are completely satisfied. So, so this is a very heterogeneous field. But I think the best method indeed is to evaluate those slides, but I do not think it is possible to serve the clinic in that kind of way, because as we know, this needs a lot of manpower. So a skilled pathologist with subspecialty cytopathology for 1 or 2 rapid on-site evaluation, I have to admit that this is something like a waste of time. So it needs to be in a reasonable setting. But I prefer those physicians that are basically skilled in cytology, so they at least can evaluate the cellularity of the specimens, so the detection rate is much more higher than blind punctation.
Okay, thank you very much.
Thank you very much, Dr. Kelly, Dr. Andreas, for a very interesting question. Do we have any more questions for the speakers? If so, please post them in the chat box. If even after this you have any queries or you wish to contact the presenters, the emails and contact details are available with the organizers, and they will be more than happy to pass them to you. In the case of no more questions, I would like to announce that we shall adjourn for a short lunch break, and we shall be back with the second session chaired by Dr. Andreas. Thank you so much. Please stay logged on and await further instructions for the organizers for the commencement of sessions. Thank you so much.
Gern
So, dear colleagues, I welcome you to the next session after the lunch break. So maybe we'll wait 1 or 2 minutes until everybody has joined us. Okay, I see that the first speakers already, very well, already arrived. So again, welcome everybody to our next session. And this morning we had a very interesting spectrum of different diagnostic fields. We had a lot of interesting case reports that teaches us a lot for our daily practice. We have investigated some real rare. We investigated a real rare lesion series of splenic lesions, and also we received an update of abnormalities on the duct systems of the pancreas, which I find very interesting. So, and our next session will be a travel around the world. We will start in India with Dr. Inara Abia. We will go to Great Britain with Dr. Achana Bomana, and then we will change continents to Dr. Kirk Lin in Northern America. Then we go back to Russia with Dr. Inessa Telesnikova, and then we go again to another new continent. We go to Chile and listen to the presentation of Dr. Alvaro Ibarra. And the last 3 presentations we will receive from India, namely Dr. Manali Satisa and Dr. Arnav Kumar Roy Chudhuri, and finally Dr. Abhishek Gupta. Well then, so I call upon our next speaker, Dr. Inara Abia. Please go ahead.
Yeah. Thank you so much, everybody, for letting me present my work on this platform. First of all, I would like to thank everybody. I'm Dr. Nara from India. I'm going to present my study, which is a study of EGFR, and I hope I'm audible. Can I share my screen? Hello? Can I share my screen? Am I audible?
So we can hear you clear and loud.
Yeah. I would like to share my. Can I just share my screen? I think there's some problem. I'm not getting the permission for sharing my screen, my presentation. So I'm Dr. Nara. I'm a pathologist from India. I'm going to present my study of EGFR and HER2 new expression in the incidental gallbladder carcinoma, and we studied the clinical pathological parameters. It was an institutional experience from northern India. Why we chose to study about gallbladder carcinoma was that it's the sixth most common biliary tract carcinoma worldwide, and it was the third leading cause of death in northern India. And the Indo-Gangetic belt is the highest affected region for this cancer. The highest incidence worldwide is seen in Delhi with 21.5 cases per 100,000 cases. It is also associated with a poor prognosis or low survival. So we thought it is important to understand the various molecular carcinogenic mechanisms in the pathogenesis of this carcinoma, and if we could find out the use of a targeted therapy in this cancer.
Excuse me that I interrupt. Could you maybe try again to share the screen? We hear you clear and loud, which is cool, but we cannot see your screen.
Yeah, I'll just try again.
Thank you very much. Oh, this looks very good.
Yeah, thank you so much.
Yes,
what I was saying was that why we took gallbladder carcinoma, why we took up the study, was that very limited studies in the Indian subcontinent have been done on this disease, and as we know that it is a disease of progression, and in the early stages it is very rare to detect it. It is only incidentally detected, and if we thought if we could study some markers which could help us in giving us a prognostic help, which could give a palliative treatment to the patients. So this is a world map, and the areas in the in red show us the areas with highest incidence of gallbladder carcinoma all over the world. So coming to incidental gallbladder carcinoma, what it is defined as any GBC which is diagnosed during or after cholecystectomy, which is being done for a benign disease, is known as an incidental gallbladder carcinoma. And the incidence of incidental carcinoma worldwide, incidental gallbladder carcinoma worldwide, ranges from a 0.2 to 2.1%, with females and elderly people seen more in the age group. So the Royal College of Pathology has given us a statement for histopathological examination of all the cholecystectomy specimens, irrespective of the normal gross and morphological features, as they can mostly be misleading. The aims and objectives of our study were to evaluate the role of EGFR and HER2 in incidental gallbladder carcinoma, and to study their clinical pathological parameters in relation with the incidental gallbladder carcinoma. Our study was a descriptive cross-sectional study over a two-year period in which we took all cases of histopathologically proven gallbladder carcinoma, and we subtyped and studied the incidental carcinomas as a separate group. This was done in the Department of Pathology of Hamdard Institute of Medical Sciences and Research. The criteria for inclusions which we took were all adults more than 18 years of age, both male and female patients, and histopathologically confirmed cases. If any case had an associated malignancy or a prior treatment in form of surgery, radiotherapy, or a chemotherapy, we excluded those cases, and also cases which we could not prove histopathologically, but there was a clinical suspicion, we excluded those cases. All the cases were studied according to a well-formed performa, and all the investigations and clinical examination and details were carefully noted in all the cases. We did a CA 19-9 level for all the cases later on, which were found to be incidental. Initially in the study for all cholecystectomy specimens, we did not do a CA 19-9 level, but cases which were incidentally proved, a CA 19-9 level was followed up. We compared a before and after cholecystectomy diagnosis. A detailed grossing of all the cholecystectomy specimens was done. In case a tumor was found, it was studied, the location, configuration, dimension, a descriptive a descriptive feature of the tumor, the consistency, the color was studied. H&E slides were studied. The samples in our department were received in 10% buffered formalin. They were not kept in formalin for more than 8 hours, HER2/neu and EGFR being very sensitive markers. So after an 8-hour immersion of the samples in formalin, they were grossed and studied. Staining was performed for EGFR and HER2/neu, and with all the slides, with all the batches, we put up a positive and a negative control. For EGFR, the positive control was skin, and for HER2/neu, we took a 3+ known case of CA breast. The grading of IHC was done according to the CAP ASCO scoring protocol, which is followed for carcinoma breast as it is widely accepted. And in gallbladder carcinoma, all the studies which have been done have a variable number of grading systems which was used, and this was the only more reliable grading system which we could find. So a score of +2 and +3 was taken as a positive score, and all the cases were studied in duplication. So over this period of 2 years, we received 2,084 cholecystectomy specimens, and out of which 40 cases were of gallbladder carcinoma. Out of these 40 cases, we had 29 cases of incidental gallbladder carcinoma. So the incidence of gallbladder carcinoma in our institute, in our region, was found out to be 1.9%. And the incidental gallbladder carcinoma was about 1.3%. One consistent finding in our study was that all the cases were associated with gallstones. The mode of presentation of our cases of gallbladder carcinoma, 73% of the cases were incidental, which is quite high a number. We had a female preponderance in our study. Maximum number of cases were ranged from 41 to 60 years of age, and in the third decade we had the least number of cases, showing one patient. Family history in the second and third degree relative was present in 17% of the cases of incidental gallbladder carcinoma. Also, nausea was the only consistent symptom which was seen in 27 of the cases. Dyspepsia and right pain in the upper abdomen followed it. Patient presented with vomiting, and one specific pattern of vomiting which we saw, which was seen in 9 out of these 11 patients, was that they had multiple episodes, around 5 to 9 episodes of bilious vomiting, 5 days prior admission, and that was the reason of admission. No specific cachexia or cancer symptoms were seen in any of the patients which were admitted. Among the clinical diagnosis, it ranged from symptomatic cholelithiasis, which was the most common presenting symptom, and we had one patient presenting as empyema also. This is a gross photograph of one of our cases, which on grossing showed a focally thickened gallbladder wall. But on ultrasound and per-op, no abnormality was found. Only one thing in this case was that this was a difficult surgery. This is another gross photograph of one of the gallbladders. On cutting, we found a few papillary excrescences. We went back and tried to retrieve the ultrasound details, but nothing as such could be seen on the ultrasound. So the surgical procedure which was followed in the cholecystectomy cases, all the cholecystectomies currently are done by lab. Only 11 cases of our 2,084 cases were open cholecystectomies because they were preoperatively diagnosed as gallbladder carcinoma. Among our incidental carcinoma, 7 cases had to be converted to open. And this was due to a difficult surgery and lot of adhesions. And all these patients were in the younger age group. The histopathological diagnosis ranged from a conventional adenocarcinoma, squamous cell carcinoma, and one case of adenocarcinoma with a xanthogranulomatous cholecystitis focus. So this is a microscopic picture of low power, which shows us a full thickness gallbladder. The wall was atrophic, which is shown by the red arrow, and the glands were reaching up to the muscle layer. This is another microphotograph of a squamous cell carcinoma of the gallbladder, which shows malignant glands in nests and sheets. This is the H&E picture, and the black arrow points towards the malignant squamous epithelial glands. This is another microphotograph, a high-power H&E microphotograph showing squamous cell carcinoma, which shows invasive nests and sheets of these atypical squamous cells. And there's a lot of dense lymphoplasmacytic infiltrate, which we could see. According to the stage, the gallbladder carcinomas are diagnosed as early and late carcinomas. T1A and T1B being the early gallbladder carcinomas. About 20 cases were in the early stage, and the rest of the cases were in the later stage of the gallbladder carcinoma. The purpose of early and late staging, dividing them into early and late staging, is that in early stage gallbladder carcinoma, surgery is said to be curative. Coming to the grade, there were only 4 cases which were poorly differentiated. The rest of the cases were equally divided as well and moderately differentiated cases. This is a microphotograph of a well differentiated adenocarcinoma. It's a H&E photograph scanner view showing these malignant glands which can be seen reaching up to the muscle layer. This is another H&E scanner low power view of a moderately differentiated adenocarcinoma, and it shows these malignant glands in cords and sheets. This is another micro photograph of adenocarcinoma, of a poorly differentiated adenocarcinoma, and these cells are seen in cords and they're singly lined. Coming to lymphovascular invasion, it was seen in about 7 cases. This is a microphotograph, high power, showing lymphovascular invasion. This is the perineural invasion was seen in 4 of the cases. This is a microphotograph, high power view, showing perineural invasion. Coming to our markers, EGFR was the first marker which we put on. EGFR and HER2/neu were subsequently put on in 2 different batches with a positive and negative control. So when we compared and checked the statistical significance of EGFR with all the parameters, clinico-pathological parameters, it was found that the histopathological stage and grade were statistically significant. These are microphotographs. This is a microphotograph, high power view of EGFR showing no membranous staining. There is no staining in the glands. This is another microphotograph of EGFR showing a well differentiated adenocarcinoma of gallbladder. And this showed a scoring of 1+, which was incomplete and or barely perceptible staining, which was seen. This is another microphotograph showing a 2+ positivity of EGFR. And 2+ positivity was a positivity. It was either if it was weak or moderate in more than 10%, and if it was circumferential, it was taken as a 2+ positivity. This is another micro photograph showing positivity for EGFR. This was a 3+ positivity in our case. This is another microphotograph of a well differentiated adenocarcinoma showing a 3+ EGFR positivity. This was a microphotograph of a moderately differentiated adenocarcinoma showing a 3+ EGFR. This was poorly differentiated adenocarcinoma showing a 3+ positivity of EGFR on low power. This is another microphotograph, a high power view of the same poorly differentiated adenocarcinoma showing a 3+ positivity. Coming to histopathological stage, In the later stages, EGFR was seen positive in all the cases. In the early stages, in the early gallbladder carcinoma, in the T1B stage, 5 cases were negative, and in T1A, 4 cases were negative for EGFR. So, EGFR showed a positive correlation which was statistically significant. When we come to the grade, all poorly differentiated EGFR were positive or poorly differentiated gallbladder carcinomas were positive for EGFR. Lymphovascular invasion and perineural invasion did not show any statistical significance, although all the cases in which lymphovascular and perineural invasion was present had a positive EGFR, but even the cases where it was absent, most of the cases had a positivity for EGFR. Coming to HER2/neu, which is the other marker which we studied, HER2/neu only showed a statistical significance with the grade. So this is a high power microphotograph. This is a low power microphotograph of a well differentiated adenocarcinoma of the gallbladder, showing a 2+ positivity for HER2/neu. This is another microphotograph of a moderately differentiated adenocarcinoma. It showed a 2+ positivity. This is another microphotograph of a well differentiated adenocarcinoma of the gallbladder, showing a 3+ positivity for HER2/neu on scanner on low power. This is a high power microphotograph showing a very nice circumferential positivity. It was seen in more than 10% of the glands, and most of the HER2/neu staining came out to be really very well in our study. So this is so it showed that all poorly differentiated carcinomas were negative for HER2, but the well differentiated carcinomas and moderately differentiated carcinomas were predominantly positive for HER2/neu expression. On grade, poorly differentiated carcinomas showed a loss of HER2/neu expression. Another consistent finding which we saw in our HER2 case was this. This is the intratumoral heterogeneity which was seen in our cases. This was a well differentiated case of adenocarcinoma of gallbladder, and it showed us intratumoral heterogeneity. That means one part of the case showed us a 1+ positivity, but the other section showed us a positivity of 3+. And intratumoral heterogeneity is well established in breast carcinoma as well, and is associated with a very bad and poor prognosis. Coming to the discussion, so EGFR immunoexpression has been studied in gallbladder carcinoma, and it has shown a variability of 100% immunostaining to as less as 11%. In our study, the immunoexpression was found out to be 72.5% for EGFR, and for HER2/neu expression, the studies which have been done, they have ranged HER2/neu expression to a highest of about 90% in carcinoma in situ, with as low as 9% to 6% in some of the studies. Our studies showed a HER2/neu immunoexpression of 32.5% in the cases which we had. So I would like to conclude with the fact that there is a very possible good scope of targeted therapy in carcinoma of gallbladder, which is promising results with regard to immunoexpression of EGFR. HER2/neu expression was far more in better differentiated tumors and the early stage tumors. And this suggests a very good and positive possible role of HER2/neu as an early event in carcinogenesis of gallbladder. Also, both these markers, HER2/neu and EGFR, respectively can be used as a predictive and prognostic markers. And further rationale to explore the anti-HER2 and anti-EGFR therapy in gallbladder carcinoma can be explored. Our study was a limited study, and it is one of the stepping zones. It is one study which can act as a stepping zone for other large scale studies to identify the existence of patients who could benefit from targeted therapy, particularly in advanced gallbladder carcinoma. Also, our study was resource limited as we could not perform FISH on our cases. We did not have any external funding which was there. there are a few recommendations which we would like to give on the basis of our study. Is that GBC being the most common biliary tract carcinoma worldwide, being associated with a poor prognosis, it should be dealt differently. More studies should be conducted, mostly in the northern part of the country. In rural health, there can be a health policy and decision making changes for people with just symptomatic cholelithiasis being treated in a different way so that we can elevate our health system. And there is also a necessity for an archetype marker for GBC that will help us diagnose and prognosticate the disease and choose our modality of treatment accordingly. So opportunity to make a headway in basic understanding of biology of gallbladder carcinoma and management paradigm is really necessary. And the most important thing which we would like to recommend was that accurate molecular characterization of the tumor is necessary so that we can enroll the patients in clinical trials so as to define which patient group would benefit from targeted therapy. These are the references. Thank you so much. Thank you so much.
Thank you so much for your comprehensive analysis of your collective of gallbladder cancers. Nice pictures and very thorough immunohistochemically analysis. So, and now I would like to call up our next speaker. This is Dr. Achana Bomana. Let's see, well, she's online, which is cool. And she would like to tell us something about D240 Podoplanin marker to distinguish primary skin adnexal tumors from adenocarcinomas metastatic to the skin. Okay, we cannot hear you right now. You are still muted. Oh, well, they should be all right. Well, you are not muted, but well, at least I cannot hear you, unfortunately. Right now we cannot hear you. So maybe you could just try to turn your microphone on and off, maybe, just to check whether it's enabled correctly. Now it's okay. Now it's off. So maybe we try to. So again, you are unmuted, but we cannot hear you, unfortunately. Maybe could you use something like a headphone or something like that? Just in case your microphone on your PC does not work properly. Okay. Electronically, you are muted right now. Maybe you can try. Yet now you are unmuted. Okay, but we cannot hear you, unfortunately. Oh, what a pity. Well, what we can do, maybe we can give you some time to fix your techniques, and we will call on the next speaker, so you've got plenty of time to try to improve your devices. Don't panic. I'm sure you'll manage this. In the meantime, I'm very proud to call our next speaker. So we travel to Northern America, and the next speaker will be by Dr. Kirk Lin, and he will report on molecular testing and precision medicine and prostate cancer. Dr. Kirk?
Okay, let me try to click the, well, it's early for me, but Christmas comes early. I should click share screen, share.
Very well, we can hear you and
can you hear me now?
Yes, we do.
Okay, and let's see. Yes. Can you see my screen?
Yes, perfect.
Okay, good, great. Okay, good morning. It's morning my time. It's in the afternoon your time. Thank you for this opportunity to present some of my work and my review. I have nothing to disclose. I am a GU pathologist working at a largest group in the United States. We have about 200 providers in multiple locations. This presentation is for education only. These three professors contribute fair amount of contribution to my child, Dr. Lin from the University of Washington, Dr. Evans from UC Davis, and Dr. Rader from UCLA. Today, we will go over briefly a few subjects: biomarker and screening, molecular risk assessment, genetic testing, and counseling. And if we have enough time, I will talk a little bit about precision medicine. Prostate cancer is the most common skin disease and second leading cancer death in the States. 1 of 6 men will have prostate cancer during their lifetime, and 1 of 36 of them will die of it. There are about 200,000 new cases this year. PSA is still the most common test available and still is, but it's not specific. There are several molecular-based tests available to provide more specific tests. These are the list of some of them, and there are still more in developing. PCA3 is a protein and is 60 to 100 times higher in prostate cancer than benign prostate. Also, it is more specific. So this is the diagram. The way we do it, you need to massage the prostate, collect the urine, and run the test. They test as mRNA and express as the ratio of mRNA versus PSA mRNA. There's noise in it. There's less noise, I'm sorry. Let's go back to the previous one. Now, all these tests are different. The second one is a Michigan prostate score. It tests 10+2 ERG and PSA3 gene. Select MD tests 2 genes, and Confirm MD tests 3 genes. 4K score is a combination of 4 different proteins, and ExoDx tests 3 genes. The last one is single nucleotide polymorphism. Now, the PCA currently is very popular in my practice. And if you see from this figure, there's a sharp difference. At the reading at 35 is above 35. There's more likely probability to have cancer. So the cutoff level is set at 35. The sensitivity and negative predictive value is above 90. So I always explain to the clinician that the easy way to remember this is that if the PSA score is 40, and there is about 40% probability to have positive biopsy. If the PSA3 score is 70, and there is a probability 70% to have positive biopsy. It's easy to remember this way. Now, if we plot into a AUC figure, so PSA3 has about 0.865, which is very high. Next one we are going to talk about a little bit is Select MDX. Both Select MDX and Confirm MDX are from MDX House. Select MDX is for before the biopsy. Equivalent is similar to like PSA before you do the biopsy. And the Confirm MDX is after you do the biopsy. If the biopsy is negative, and then you run the Confirm MDX. Now, when the first time when you have biopsy, if it's negative, and usually the patient will have some anxiety or something. So it's better to run the test. And Confirm MDX addresses the biopsy sampling error and false negative dilemma. This is the one we use in my practice. As I said, we have 200 providers. And this is the cutoff level for Confirm MD, 15.8. And this test is a well-validated epigenetic test that guides the detection of occult prostate cancer on the patient previously negative biopsy tissue. If Confirm MDX is negative, and then you don't need to do the immediate biopsy, you just need to watch the patient. Next one we are going to talk about is ExoDx. This is newest one from the list, and this is the most promising one because it is relatively specific, and also it uses regular urine. You don't need to do the DRE. All the other you need to do some sort of procedure like a DRE, biopsy, or blood draw, or a swab or something, but this one just use regular urine. And they test mRNA or PSA3 protein, 10+2 ERG, and ETH transcription factor to predict high-grade cancer. The sensitivity and negative predictive value is also above 90%. And this is the flow chart for this test. The indication of the test, how it works, and how to use it is all here. Now, if you use ExoDx combined with MRI, you can see that you don't miss any high-grade cancer. At the same time, you avoid about 10% of unnecessary biopsies. Finally, we talk a little bit about single nucleotide polymorphism SNPs. It is a DNA sequence variation occurring when a single nucleotide differs from the norm. It carries some risk of prostate cancer or in any other cancer, not only prostate, and is kept through the heredity. There are slightly more than 100 SNPs identified through genome-wide association study, and this may provide an excellent way for population-wide screening. However, this is relatively new and still ongoing study. Here again, we see this table again that different urologists use different things. But as I say, the PSA is still the king. Here's why. There are some disadvantages of this test. One is this test can only predict high-grade cancer, but low-grade prostate cancer may undergo undetected. Two, this test can only perform at one or a few centers only. It is not practical for population screening. Three, these tests are very expensive, ranging from $300 to $2,500. Now PSA, it costs only $50, and you can do anywhere in any lab, even in the outpatient clinic. The current practice pattern in my practice is that if the PSA is high, we do the biopsy. If the biopsy is negative, and then we run the confirmed MDX or PCA3. Now, this is, I forgot to move here. Now, so let me ask a question. In your mind or to your experience, what is your PSA level? What do you think is the cutoff level? Please type in the question box, and I will answer this question later on. What is your normal PSA? Do I see anything? That's okay. Let's move on. Now, next topic, the same topic, but the different session is genomic assays for localized prostate cancer. This is a huge market because prostate cancer is a slow-growing disease, and a lot of men with prostate cancer will not die of it. Therefore, active surveillance is an excellent way to manage this. NCCN guidelines recommend any form of molecular analysis to confirm the candidacy for active surveillance. Here are the major available tests: Polaris from Myriad Genetics, Oncotype from Genomic Health, Decipher from Genome Diagnosis, Protovism from Basri Lab, ProMark from Metamark, and PTEN Plus from myself. PTEN Plus is a cocktail test I put it together. Now, Protovision uses 2 markers only, and because it's high false positive, false negative, that people don't use it anymore. ProMark also, I don't see anybody using in my practice. So we basically will talk about in detail of 3 or 4 tests. And here is the screenshot from NCCN guideline. It shows that low-risk cancer should, let's see, can I see anything here? Yeah, so molecular analysis should be recommended for low-risk cancer. Let's take a look closer. Okay, I put things together closer. Prostate cancer is heterogeneous, genetic, and multifactorial. The biologic risk and biologic behavior is very important, but not included in the NCCN risk grouping. Sometimes a low-grade prostate cancer may harbor aggressive malignant cells. On the other hand, sometimes some of the unfavorable intermediate may be silent. Therefore, there's a need to measure the biologic behavior of the cancer cells. So here's why there are so many new tests available, and there are still more in developing from different companies. And here is a comparison of the 4 tests we use most common. They all provide similar prognostic information: Polaris, Oncotype, P10 Plus for my own, and Decipher. They all report the risk of the prostate cancer, the probability of the disease progression, and 10-year survival. If you look at the bottom, the cost is different, and the test I created cost the least. Now, here is the genes or components of each test. The Polaris tested 31 genes, that all related to cell cycle progression. Oncotype is 17, and P10 Plus tested 6 markers: P10, tumor suppressing gene, ERG, P67, as we all know, P27, MUC1, a T-cell protein, and P53, of course, oncotype mutation. Now, Decipher tests 22 genes. Decipher is based on the protective specimen. It's not designed for biopsy. I'll come back to the test I test here. That the reason I put this test together is I feel the test I have is from different aspects of the malignancy, and also it is a sort of global evaluation of malignant cells. Like it consists of molecular, immunohistochemistry, and cellular component. So it's more rational this way. During the malignant transformation, different molecule events happen at different locations, such as P27 deletion here, ERG abnormality happens here, and P10 lesion right here. The P53 is down here. P10 is a tumor suppressor gene. If the P10 is deleted, the cells will grow unchecked, which is malignant. And ERG may be in the form of fusion, deletion, or insertion. This is a published data that, as you can see, survival if the P10 deletion together with abnormal ERG, it has the worst survival. Another paper published from clinical cancer research, also showing P10 deletion and P27 deletion at the same time, had the worst survival as well. Now, MUC1, MUC1 is a T-cell protein. If it is upregulated, it tends to have tumor progression and metastasis because a T-cell protein. A survival study, you can see that if the MUC1 is upregulated, it also has poor survival. People may ask, what does the P10 do? P10 plus in my own days, what does it do? How does it do? As compared to all the other test modalities, is a reminder that P10 plus test can consist of these components. And actually, these components are very familiar to our pathologist community. So here is the initial data. I just studied this year. I don't have many cases yet. If you look at the low risk group here, they are very comparable. About half of the patients we tested, half of the patients can be safely in active surveillance. And again, this data has been accepted to present at next year United States Canadian Academy meeting next year in Baltimore. But it's again it's online. Now, what is the significance of all these expensive tests? The test is quite expensive, about 4,000. The only the test I have is about 1,000, but still expensive. Is it worth for the money? So let's talk about this figure. In the past, when a man has newly diagnosed prostate cancer, they are nervous. They don't have a clue what to do. So most of them will receive aggressive treatment like prostatectomy or radiation. Now, with this test available, we'll be able to measure the risk of cancer. So more than half the patient can be at active surveillance. So they don't do anything, just watch every year or follow-up biopsy once a year. This is huge savings, of course. And also that so-called over-treatment is not the question, it's out of the question anymore. People keep complaining there's over-treatment, over-diagnosis. I don't think so, because we find the cancer, we watch them, we don't need to do anything after the test. So let's take a look at actual two cases comparison here. And these two cases are almost identical, 65-year-old, PSA 4.7, normal DRE. Cancer involved 35% and 1 out of 12 core. The other cases are very similar. Or the recent grace material. Okay, now most of us are histopathologists. Please help me. I'm the pathologist as well. So let's assign the Gleason grading here. Take a look at the picture and get the Gleason grading. I'm sure all of you got it. As you can see here, that there are most large area of open glands, which is pattern 3. Also, there is tiny area, fused gland or needle-shaped glands, maybe 4. So these two cases, of course, 3 plus 4 is reasonable. Now, let's take a look. Let's take a look the molecular test gauging. The case 1, 3 plus 4, it is low risk on both tests, Oncotype and P10+. So this man, we go to active surveillance. Now, next case, the same situation, but it's high risk. And of course, you need to go to prostatectomy. So this is why this test is getting into practice. Now, and for this actual 2 cases, I went back to look at the slides. I still couldn't tell the difference. There's no difference on histology. So the benefit of active surveillance is maintain normal life, keeping normal workforce, healthcare savings. Some men will never die of the prostate cancer. They may die of something else, but the prostate cancer may just silent here. And of course, overdiagnosis and treatment is out of question anymore. Now, I get this question all the time: what tests we should use and on what patients? In other words, is what is the best bang for the buck? So, and then we need to go back to this table to take a look. Now, all these tests are most commonly used. Decipher is designed for prostatectomy. It's rarely used for the biopsy, but people still can use it. They report similar information. They provide similar information. Oncotype has a little bit more edge here because it has it reports risk of high-grade cancer, also reports the risk of PT3 disease. Now, the tests I have are not much different, and it also costs less. The ranking at the bottom is for myself. I try to be as fair and as objective possible. For me, I'm not as good, but as time goes on, as I have more clinical investigation, I show that this is one of the best. Our urologists use all the tests are available The urologists under my direct surveys use more P10+, while the other locations tend to use oncotype or polaris. Men with Gleason 3+3 and 3+4 are most applicable. Sometimes 4+3, the clinician usually wants it, and I run it for them if they order it. In summary, patients diagnosed with localized prostate cancer may face multiple decisions. Active surveillance is an excellent regimen for low-risk patients. Molecular tests for risk gauging is an effective way in selecting patients for this purpose to ensure patient safety. Now we are moving to next session, genetic testing and counseling for prostate cancer. In this session, we'll answer the question why, who, when, and how. Probably you've seen this before. We have discussed biomarker screening and risk assessment. Some of you may have heard of genetic and genomic testing for metastatic prostate cancer. Recent development shows that genomic mutation happen throughout the entire spectrum of the disease, even at early stage of the localized prostate cancer, throughout the entire spectrum. When this happens, the malignancy is usually high-grade, aggressive, and sometimes it goes through family pedigree. As we all know, the somatic mutation can happen in any cells in the body and is not inherited. For germline mutations, it happens in the eggs, inherited in every cell in our body, and passed on in the family. Carcinogenesis is multifactorial. Some genes confer very high risk, others don't. Some mutations are common but have a low impact on prostate cancer. Some rare but with high penetrance as those in this area. These mutations showing in this area has large impact on prostate cancer. The majority of prostate cancer is sporadic. Only about 10% are hereditary, and that are usually due to single inherited genes, single inherited mutations such as BRCA1 or BRCA2 or MSI. MSI is part of Lynch syndrome. The lifetime risk is greatly increased, and the cancer is usually aggressive. This is almost the landmark paper from New England Journal of Medicine. They reported about 12% of metastatic prostate cancer and maybe as high as 20%, and 5% of localized prostate cancer of germline mutations. And this is significant because these cancers are aggressive. When germline mutation happen, there is about 10-fold more rate to develop cancer. And again, these cancers are high grade, aggressive, and usually metastatic with poor survival. This is why and where the genetic testing come in. Family history is very important. It goes beyond prostate cancer. It includes breast cancer, ovarian, colon, endometrium, leukemia, etc. And so in clinics, for the clinician, they need to detail history. Here is the example of a family pedigree of BRCA2 mutation. A mother died of breast cancer, or a daughter died of ovarian, another daughter died of breast, and down in the line, a son or grandson is a prostate cancer subject, and you see down the line a lot of them. The NCC guideline recommend familial assessment of following situation. So this is not only prostate cancer anymore, it includes everything. So if there is a metastatic prostate cancer, you need to do the genetic. If there's a personal history of Gleason 7 with one close blood relative with ovarian, pancreatic, or metastatic other cancers, or two relatives with breast or prostate cancer at any grade or as Jewish ancestry, and introductory or prepreformed prostate cancer is always indication. Now, I summarize this just for the prostate cancer only, that as you can see, the high-grade cancer and metastatic also are always recommended to have a genetic testing. For low-grade cancer, low-risk cancer, if there's a strong family history, of course, you need to do that as well. Multi-gene testing is recommended. Here is the list of the genes mutation here. BRCA2 is most common one. But if you test 10 genes, it covers 95% of the entire mutation. So you cover everything. A study from Europe on more than 3,000 men at young age, aged from 40 to 69, when the PSA is higher than 3, they did the biopsy, and they showed that those men with BRCA2 mutation have three things. One, higher incidence of prostate cancer. Two, young age at diagnosis. Three, high grade. As you can see on the left here, that these are BRCA2 mutation carrier, and the cancer are used, half of them are high grade, 3+4 or 4+3. On the right are non-carrier subject that most of them are 3+3. And of course, most of you are histopathologists, and these are the pictures of histology. Obviously, 4+3 here and 3+3 here. The survival study shows that BRCA2 and BRCA1 mutation with prostate cancer was worse survival in these two here. It happens to localized and metastatic prostate cancer. The germline mutation status can guide chemotherapy. Patient A developed drug resistance. The PSA went up here. So they run the mutation test and find the mutation. They switch the chemotherapy and add carboplatin, I believe, and bring the PSA down and relapse, and add another cycle of chemotherapy. Patient B, you see that there was a drug resistance right here and PSA relapsing. And here again, they tested that germline mutation and switched or added another chemotherapy. And the PSA is sharp decrease here. Elaprib is a new drug that just approved for prostate cancer. This is case report. As you can see, the PSA keeps rising. Nothing is working. The PSA has been rising until they test the germline mutation right here and add the switch to a new drug, elaprib, and you see the sub decrease of PSA here. And the test is done right here, I believe. Because the germline mutation, that triggers a genetic counseling and cascade testing for siblings. This man has germline mutation with prostate cancer, and he will have new treatment, of course. At the same time, the entire family siblings should get genetic testing and counseling. Now, a few minutes ago, I asked you about the normal PSA cutoff level, and now let's talk about it. The PSA cutoff level is changing depending on family history, personal DRE, this director examination. And two surprise here. Generally speaking, for general population, 2.5 is the cutoff level for PSA. However, for mutation carrier, the PSA could be as low as 0.75. So if PSA above this level, we need to screen those subjects. To be honest with you, I've seen prostate cancer with the PSA of 0.5. In summary, 12% of men and probably as high as 20% with prostate cancer, with metastatic prostate cancer, and 5% of men with localized prostate cancer inherited germline mutations. All high-risk cancer should be tested. Multiple gene panel is recommended. Cascade testing for family members should be in place as well. Inherited susceptibility to prostate cancer is important across the entire spectrum of the disease, from screening to advanced cancer. Now, we are moving to the last part. Let me take a look at time. I don't know how much time I have, but I should have enough time. Maybe I run too fast, but that's okay. Now, we are at the last session, precision medicine in prostate. Are we there yet? You've seen this before. The molecular events of prostate cancer happens all along from begin, from early to the late, from localized to advanced disease. And NCCN recommends NCCN risk group are overlapped. These groups are overlapped and not truly representative of actual molecular nature of the disease. So precision medicine comes into fill the gap. It involves from population screening, genomic diagnosis, risk assessment to therapy and surveillance. Generally speaking, the all three parts we just discussed previously are part of the precision medicine, like molecular biomarkers, genomic risk assessment, and genetic testing. But in this session, we mostly focus on therapeutic applications of precision medicine in prostate cancer. As we all know, we are in the field of diagnostic pathology, and this may be beyond my capacity to discuss in depth. And I will just do some brief introduction. There are many somatic genes, somatic mutation and germline mutation prostate cancer. Some of them can be used for diagnosis or prognostic analysis. Others may be used for targeted therapy. So here is the list of the somatic mutation. You will see a lot of them. And here again is the list of germline mutation. Precision medicine in prostate cancer is actually far behind lung cancer, breast cancer, and colon cancer. So we are actually catching up. Our goals are to perform molecular interrogation to provide insights into tumor biology and treatment. For population-wise, to accumulate genomic data and identify patterns and pathways, and ultimately for individual patients. There are many mutations during the course of molecular transformation. Some of them are actionable, some of them don't. These actionable mutations can be used as therapeutic interventions such as AR pathway or DNA repair defects. If we use DNA repair defect as a biomarker, and we take a look at these two group patients here, that the biomarker positive, which is DNA repair defects. It responds better on the new drug olaparib. On the right side, I'm sorry, on the right side, that on average, it lives 4 months longer than the previous one, and there's a clear separation. There's a clear separation of these two groups. The blue line is the subject, biomarker positive subject on olaparib. The histology diagnosis and classification are still the gold standard in practice. However, when it comes to high-grade prostate cancer or metastatic prostate cancer, the histology evaluation is not good enough. There was a study of 300 men with metastatic prostate cancer. They found that 39% of them had different molecular profiles and defined as atypical intermediate carcinoma, and 12% has small cell neuroendocrine carcinoma. So they found 61 gene signatures in treatment-induced small cell carcinoma. These 61 genes are plotted into a panel, and here it shows the green area on the left upper is a treatment-induced small cell carcinoma, and the regular adenocarcinoma is the yellow area. So this gene signature is able to differentiate between these two histology groups. Now, these findings may and can translate into patient care. The figure on the left is the survival of non-treatment induced. It's slightly better. Now, but the difference is very small. You can see the 45.5 versus 36.6. Now, if you look at the gene signature classification, that there's a big difference here. That is 41.7 months survival versus 17.6 survival. So this is a significant again. So this tells us that the gene signature is much more definitive in determining the outcome of the patient with treatment-induced small cell carcinoma. The current genomic bridge test, like Polaris Oncotype or P10+, we have discussed in part 2, are still in version 1. The future genomic test will be version 1, which will be the combination of Gleason score, clinical prognostic signatures, and hallmark gene through next-gen sequencing. Here is what it means and how it looks, that all the information, including Gleason score, clinical prognostic signatures, and hallmark genes, are plotted in the grid. And the artificial intelligence will find the risk profile for each specific patient. In conclusion, the precision medicine in prostate cancer based on genomic is exciting and has a bright future. Although the current application is still limited, the influence across the genome are vast and complex, and are still at the early stage of development. Genomic data correlates with histology has important role at real practice. Combination of genomic mapping with Gleason score and other clinical prognostic signatures can provide more and better therapeutic and prognostic information. The take-home message for all 4 parts of presentation today are several molecular tests available for prostate cancer screening. However, PSA is still the most favorable method or the other molecular tests are mostly used on negative biopsy patients. For patient safety, NCCN recommends molecular gauging for active surveillance, and this is the state of the art in practice. Germline mutation and somatic mutation happens throughout the entire spectrum of the disease. Genetic testing and counseling are recommended if clinical indicated. The precision medicine prostate cancer is promising, although it's still in its early stage. Thank you for your attention.
Thank you, Dr. Kirk, for your very comprehensive review about predictive and prognostic marker in prostate cancer. I think this covers the field very, very, very thoroughly. So now I have the honor to introduce our next speaker. And I see this will be Dr. Archana. See if we can get her on the screen.
Hello. Hello.
Oh. Yes, we understand you, but we do not see you. So let's see.
Are you able to see me, sir?
Yes, and in addition, we hear you, which is cool. So
Yes.
then I introduce our next speaker, Dr. Archana.
Are you able to see my screen, sir?
No.
Yes, sir.
Okay, now we see your screen, and just a little interruption. Due to the fact that we are able to discuss in the group and without interference, I would like to ask if someone has any questions regarding Dr. Kirk's presentation. And if you do not have any questions right now, of course, you can keep this in mind or write it in the chat. There will be a possibility to come back to this questions later if it's now too acute to formulate a question.
Yeah.
So anyway, so if there aren't any questions, we go forward to our next speaker, which is Dr. Archana Bomana.
Yes, sir.
So we hear you, we see your screen, and we are looking forward for your presentation.
Well, first of all, I would like to apologize for the inconvenience I have given. I want to go ahead with my topic, sir. Yeah. A very good afternoon to all the delegates, speakers, chairpersons, and the participants. Hope you all are having a great time attending this virtual digital conference. It is really good opportunity for all of us to keep updated with the information that we are sharing on this conference platform. And today, I feel honored to present my topic amongst all the eminent pathologists across the globe. My topic for today's presentation is Podoplanin D240 to distinguish primary skin adnexal tumors from adenocarcinomas metastatic to skin. So many a times clinicians are posed with a diagnostic dilemma, or could be challenging sometimes to offer a clinical diagnosis in an elderly patient presenting with skin nodule as a primary presentation. or sometimes it could be a skin swelling in a previously diagnosed carcinoma patient. In such instances, we pathologists can offer appropriate diagnosis by taking a biopsy, studying the slides, running appropriate IHC marker to confirm it. Thus, my topic covers the importance of Podoplanin, also known as D240, in differentiating primary skin adnexal tumors and metastatic deposits of adenocarcinoma detected elsewhere. Coming to the introduction proper, the major cause of cancer mortality is the metastatic spread of the tumor cells that can occur via the lymphatic pathway, as we all know that. Recent research has indicated that growth of lymphatic vessels, what we term as lymphangiogenesis, within the vicinity of the solid tumors correlate with the lymphatic metastasis. The cutaneous deposits of malignancies mimic various skin lesions. They are seen in patients with advanced disease, but can be one of the primary presenting lesion which heralds a poor prognosis. Persistence of cancer in the form of metastasis even after therapy can be found sometimes. Recognition of this cutaneous metastasis alters the therapeutic plans of the patient. The most common tumor metastatic to skin is the breast cancer in my study, which has presented as a local recurrence, as a skin nodule. Also, adenocarcinomas of stomach, lung, uterus, large intestine, and kidneys are also found to be the frequent primary sites to produce the cutaneous metastasis. Coming to the IHC marker in detail, Podoplanin, it's an mRNA. It was first identified for the first time in the murine osteoblastic cell line MC3Y3E1 in 1990. It was first identified by Waterwall et al. In 1996 in lymphatic endothelial cells. It was widely accepted as a novel marker of its expression in lymphatic endothelial cells since the year 1999. Podoplanin is also known by other names like GP36, GP38, canine GP40, T1 alpha, P28.26, aggress, or M2A oncofetal antigen. It is located on short arm of chromosome 1, 36 at location 36.21. And Podoplanin gives a strong cytoplasmic membrane positivity. It is a 162 amino acid transmembrane sialoglycoprotein weighing about 38 to 50 kilodaltons. Let's see where the Podoplanin expression is seen in a cutaneous metastatic deposit, which could present as a skin nodule. Whenever there is an ideal environment flooding with pro-inflammatory cytokines, which includes interleukins, 6, interferon gamma, transforming growth factor beta, interleukins 1, beta, etc., which require SMAD activity 2, 3, and 4, and sometimes STAT activity 1 and 3. When this environment is there, we can observe that there is an enhanced expression of Podoplanin, which indirectly suggests there could be around tumorogenesis and metastasis within the vicinity. Where can we see the Podoplanin or D240 expression commonly? It could be seen in the basal layers of the epidermis, basal keratinocytes, type 1 epithelial cells of the thymus, myoepithelial cells, reserve cells of sebaceous glands, myofibroblasts of the prostate, granulosa cells of the ovary, osteoblasts, osteocytes, choroid plexus epithelial cells, follicular dendritic cells, and alveolar type 1 cells. The advantages of Podoplanin is that it is a very well-known marker of lymphatic endothelial cells, which indirectly indicates that there could be a tumor invasion. Let's see how it helps in the coming slides. It is also expressed in tumor cells of various types, like the primary skin adnexal tumors, which my topic covers. Expression is associated with a bad prognosis and a high risk for lymph node metastasis. So this marker, Podoplanin D240, is useful for both differential diagnosis and also in prediction of the tumor progression and the metastasis. Coming to the study, the aims and objectives were, in the present study, we evaluated Podoplanin immunoreactivity in a series of primary skin adnexal tumors and adenocarcinomas metastatic to skin using this marker. This marker was found to be a very useful tool to distinguish primary skin adnexal tumors from adenocarcinomas metastatic to skin with high sensitivity and specificity. The study was conducted over a period of 5 years at our tertiary institute, and it included cases for which all the clinical data was retrieved. And out of these number of years study, we received around 22,215 surgical biopsies, of which 1,840 were skin biopsies, which contributed about 8.7%. And all the cases were studied on H&D stain slides, and a definitive diagnosis was signed out. Biopsy-proven metastatic adenocarcinomas were also taken into account. The skin biopsies were fixed in 10% neutral buffered formalin, and the routine processing and paraffin embedding was done. Sections of 4 micron thickness were taken, and H&D sections were examined under light microscopy. So we have taken all the cases which clinically presented as skin nodules. We could retrieve 82 cases, out of which 77 were found to be adnexal tumors and 5 were found to be cutaneous metastatic deposits. Out of 5, many were, we noticed that many were from the breast and 1 presented as an umbilical nodule. Then we went ahead for the histopathological categorization. The first category we segregated into ecrine and apocrine differentiation, which contributes to the cutaneous adnexal neoplasms. And the second category was metastatic deposits of the adenocarcinomas. Then we proceeded with the IHC. Immunohistochemistry was performed by using Podoplanin antibody on all the skin biopsies, and the clone we used was D240. Then we recorded our observation. Out of 77 primary skin adnexal tumors, 75 had showed strong positivity, which contribute to 97.4%. And 2 of these skin adnexal tumors, they showed variable positivity, which contributed to 2.6%. On the other hand, all the cutaneous metastatic deposits of the adenocarcinoma, all of them, they showed a negative expression. They did not show any immunoreactivity with D240. So the results, in cutaneous adnexal neoplasms, it showed diffuse cytoplasmic membrane positivity in the tumor lobules of the adnexal carcinomas, and it showed a strong positivity in the basal layers of the benign adnexal tumors. However, no immunoreactivity was seen in all the 5 cases of the adenocarcinomas which has metastasized to the skin. It was a very helpful marker because it could show positivity in the lymphatic endothelial lining, and it showed diffuse positivity for this marker. Coming to the immunohistochemistry, so scanner and the hyper view of the trichofolliculoma in H&D sections, and here we can appreciate the Podoplanin expression as the cytoplasmic membrane positivity. This is another slide showing the diffuse cytoplasmic membrane positivity of D240. This is the scanner and the hyper view of malignant ecrine poroma. And here we can see the cytoplasmic membrane positivity as well. This is another scanner and hyper view of malignant ecrine poroma. Here in the slide, it showed a variable positivity, focal positivity of the Podoplanin in the tumor cells. Coming to the cutaneous metastasis of the ductal carcinoma, here we can see the scanner and hyper view in the H&D stains. Another view of the scanner and hyper view of the IHC. In this slide, we can clearly see that the metastatic metastatic deposit within the lymphatic channel had not shown any positive reaction with Podoplanin. However, the lining of the lymphatic channel showed diffuse positivity for D240. Here is another focus showing the expression of the D240 in the lymphatic endothelial lining, but there is no reactivity of the metastatic deposit within the lymphatic channel. We compared this with the another dilated channel, whether it could be a blood vessel or a lymphatic channel. So since it has not shown positivity for the D240, we went ahead to see what could be the dilated lymphatic channel. Could it be a blood vessel? So we had run the appropriate IHC markers like CD31, CD34, factor VIII. Fortunately, they have all turned out to be positive. Since here again, we can see that it has a negative expression in the metastatic deposit. So this could be a blood vessel, the dilated channel could be the blood vessel with a metastatic deposit within it. Unlike in the previous slide, we can see that this could be the lymphatic channel with the metastatic deposit, that is the lymphatic invasion with the tumor deposit. So we went ahead comparing with these standard studies according to the Hai Liang et al. According to his study, 70 out of 78 cases, 75 cases showed positive reaction, but 1.3% showed a negative reaction. On the other hand, all the 15 cases of cutaneous deposits in his study shown to be 100% positive for the D240. 100% they showed negativity for the D240 expression. When compared with our study, it showed 97.4% positivity in the skin head neck cell tumors and 100% negativity in the metastatic deposits, which can show that we were consistent with the results of the author. So discussion. Distinguishing metastatic adenocarcinomas to skin from primary skin head neck cell tumors is challenging because of the similarity of histomorphology. Immunohistochemical staining with Podoplanin helps in differentiating them. It eliminates the diagnostic dilemma in dermatopathology. Cutaneous metastasis occurs in about 0.6 to 10.4% of the patients with the cancer. It represents about 2% of all these skin tumors. They have variable clinical presentation with frequent delay and failure in their diagnosis. Thus, it could have an impact on morbidity, prognosis, and their treatment plans. Cutaneous metastasis may be the first sign of clinically silent visceral cancer. They have a poor prognosis with average survival time of few months. They could present as numerous hard nodules on chest, abdomen, or even near the site of umbilical area. The involvement of the skin is likely to be near the area of the primary tumor usually. To conclude, metastasis to skin from visceral adenocarcinomas are rare and are often mistaken for cutaneous head neck cell tumors. Immunoreactivity to Podoplanin was seen in skin head neck cell tumors, but no Podoplanin immunoreactivity was seen in any of the cutaneous metastatic deposits. Our study thus indicates that most cutaneous adenocarcinomas metastasis can be reliably separated. As a takeaway note, every practitioner should be highly suspicious of metastatic deposit when persistent firm nodules occur on the skin. Podoplanin expression correlates with lymphatic invasion, lymph node metastasis, and thus the patient outcome and their treatment and management plan can differ based on that. Although many metastatic adenocarcinomas can be recognized based on histopathologic examination, immunohistochemical analysis is an important diagnostic adjunct. Prompt recognition helps to treat the systemic spread of the cancer in early stage to improve the survival rates. These are my references. Thank you.
Well, thank you, Dr. Achana. This was a very interesting session with very beautiful immunohistochemical and histological images.
Thank you.
As we are a little bit ahead of schedule, I think it's a good opportunity. If there are any questions, we can discuss. So feel free asking direct questions to the presentation of Dr. Achana. And you can also ask some questions of Dr. Imara, and maybe also some questions about the presentation of Dr. Kirk, as we have a little bit time. So, Dr. Achana, I've got one question for the differential diagnostic aspects. In your experience, what is the positivity rate of T240 in case of melanoma?
Well, sir, we have conducted the study only on these adnexal tumors, sir, but we haven't studied on the melanoma. So in our tertiary center, we came across predominantly more number of cases with skin adnexal tumors, but melanoma we didn't come across. So our study was limited in differentiating skin adnexal tumors and the metastatic deposits of the adenocarcinoma. So my study was limited between these two diagnoses, adnexal tumors versus the metastatic deposits of the adenocarcinoma, and out of which we found predominantly all the deposits were from the breast cancer and one from the GI, which presented as the umbilical nodule. So we haven't studied the melanoma, sir, the expression of D240 in melanoma.
Thank you. Any other questions about the last three presentations? Well, anyway, if any questions come to your mind, just keep it in mind, and I'm sure in the session there will be enough opportunities to discuss some issues regarding the presentations. First of all, I would like to know whether Dr. Inessa is present. I think so. Very well. We see the picture.
Colleagues. Yes.
We also can hear you. And so I can introduce our next speaker, Dr. Inessa Telesnikova from Russia.
Okay. Good afternoon, dear colleagues. Tell me, please, can you see my demonstration? Okay. Yes.
Yes, we can see your presentation and we can hear you loud and clear.
Okay, I will start. Let me introduce myself. My name is Inessa. Thanks for a wonderful opportunity to give our presentation here. The topic of our presentation is the role of digital radiography in histopathologic evaluation and surgical breast cancer specimen after neoadjuvant chemotherapy. Thereafter, declare no conflict of interest. A little about us. We are from Russia. We work in Moscow Clinical Center. We process more than 2,000 of breast cancer per year. Now, some of the patients are participants in the randomized clinical trial study. The aim of other study was to optimize the pathological assessment of residual disease in breast cancer after neoadjuvant chemotherapy in Russia. Neoadjuvant chemotherapy is being used more frequently worldwide today. Recent years have seen a shift toward greater use of preoperative versus postoperative chemotherapy for breast cancer. Tumor response is associated with disease-free and overall survival. NEC provides us a unique opportunity to assess response to treatment after months rather than years of follow-up. However, significant variability exists in pathologic assessment methods of response to NEC, and thus its interpretation for subsequent clinical decision. Pathology complete response is a strong predictor of outcome after neoadjuvant chemotherapy. There is general agreement that PCR should be defined as complete absence of tumor cell in the breast and in the lymph node, total PCR or TPCR. On this graph, you can see comparison of disease-free survival in 7,017 patients achieving PCR according to breast cancer intrinsic subtype. PCR is a suitable surrogate endpoint for patients with luminal B and HER2 negative and HER2 positive non-luminal and triple negative disease, but not for those with luminal B, HER2 positive or luminal A tumor. The analysis highlighted discrepancies between RCB and YAGCC stratification. 41% of patients had discrepant RCB and YAGCC scores. We report both RCB and YAGCC for patients in order to identify those at highest risk of relapse. I would like focus on the role of the pathologist. The pathologist's role in the treatment and probable outcome of the patients is critical and too often overlooked. It is not uncommon so that to be no correlation between clinical and pathological methods to determine response to NEC. Clinical method had some both false negative and false positive response. So histopathologic evaluation is gold standard. The pathologist has different problems related to sampling for histologic evaluation. This may be lack clinical data or clips, for example. Also, triple negative breast cancer with little or no tumor stroma may regress without leaving a tumor bed. Detection of clinically occult lesions has problems such as, for example, not palpable, not visible. Can you see in this picture? We don't see any fibrous tissue. We analysis was 30 patients who underwent radical surgical treatment after NEC. Those patients had a non-palpable breast cancer, and for found lesions at gross dissection, we used imaging the Faxitron system. Data on the patient's tumor and surgical factors were collected. In some European and American guidelines, we found some information about the possibility of using digital radiography. It should be noted that Russian recommendations do not contain any information about it. Thus, we used a new approach in other countries. Technical consideration, big camera, adequate for mastectomy specimens, can be run in the laboratory without concern about any radiation. Small dimensions allowing it to be installed in almost any pathomorphological lab. The results are available within from 10 to 30 seconds. 10x geometric magnification with precise measurement at any level, which allows you to see pathological microfocuses invisible to the human eye. The specimen was sent within and others to a pathology lab. We were informed of the site of the primary tumor in the breast, particularly within mastectomy specimen, as well as the presence of any accompanying markers, for example, metallic clips. We used multiply in colors. Radiograph was after the specimen's margin. Margins have been oriented and inked, and the specimen had been serially sliced. Same coloring is applied to the adjacent edges of the tissue sections. Specimen radiography reports were compared to the histopathologic evaluation, microscopic and macroscopic parameters. It has been found out in the 4 grades. Its RCB0 was 57%, and RCB1 was 10%, and RCB3 was 30%, and RCB3 was 3%. Magic resection in all patients was negative. The tumor bed was detected in 29 cases using digital X-ray. Immunochemistry is not mandatory, but can be very helpful to identify, isolate tumor cell. The same in lymph node and tumor bed. The tumor bed was not reliable detected in the only one case. However, it was possible to identify photos of lymphovascular invasion in area microcalcification. So we got YPT 0 by AGCC post-neoadjuvant staging, and it is not classified as PCR. Clips and microcalcification were detected in all patients. The size of the tumor bed on the digital image was less compared to the gross examination. In this manner, removal of any clips and microcalcification is confirmed in the intact specimen, and location can be determined within the specimen, and no mechanical dislocation of the clips occurs. It is important to note that the identification of microcalcification acts as a significant parameter, since microcalcification are an indicator of a tumor bed. So in conclusions, in the case of non-palpable lesions in the breast, it is impossible to reliably measure the degree of tumor regression after neoadjuvant chemotherapy without using the Pathology Faxitron system. Due to the histological structure of the breast and fibrous tissue, it is easy to miss essential areas during a gross examination. Also, the use of this system reduced the incidence of sample redissection and the total study time. Finally, pathology has become much accepted in other departments. Thank you for your attention and for coming to presentation. As you can see in the picture, the winter in Moscow is getting warmer and we have little snow. And take care. Thank you very much.
Well, Dr. Inessa, many thanks for your very illustrative presentation. Very well. As our timing is very well, has anyone of the other people questions about the last presentation?
May I ask, Elsa?
Yes, please go ahead.
Nelson, thank you for your presentation, but I have a little questions. Total time dissections with and without Faxitron are compared or not?
What can you repeat, please? I not here.
Total time dissection with and without Faxitron.
Okay, thank you very much in your questions. Total time allow by Faxitron and dissection is more frequently.
Could you give an exact time, like how many minutes you usually dissect with the Faxitron for a usual specimen?
No, it's depend some different criteria when we sorry, I'm not sure.
Well, as far as I understood, the question was, what is the what time amount is the difference between dissection with and without the Faxitron analysis?
Maybe about 30 minutes, but it depends a lot of different parameters. It depends in specimens, kind of specimens.
Mm-hmm.
Yes, of course. Yeah, we all know that there are little sections,
yes,
large
yes,
sections, of course.
It's a lot of parameters.
Mm-hmm. Thank you.
Any more questions? Well, then it's my great honor to introduce our next speaker. This will be Dr. Alvaro Ibarra from Chile. Welcome, and we're hanging on the edge of our seats to listen to your presentation. We do not hear you. Could you just... we still cannot hear you, but we see you.
now?
Perfect, we hear you.
Okay. First of all, I would like to thank the organizing committee for the invitation. The pandemic has produced a global health, economic, social, and personal crisis, much pain. But as a positive effect, we have never been so connected before, and this meeting is a demonstration of it. In our days, the review of the material from external biopsy in common breast pathology is necessary. There are frequent disagreements with no or minimal effect on treatment. Important difference in morphological diagnosis are between 80 to over 25%. And in the interpretation of immunohistochemistry markers from more than 3% to over 41%. In nowadays, caring for the patient with breast cancer is multidisciplinary, with a large interactive team. The multidisciplinary team, among others, ensure correct diagnosis in triple approach, with the agreement between the clinicians, radiologists, and pathologists, because they form the core of the will produce adequate staging of the general condition of the patients, comorbidities. They will make recommendation for therapeutic management, long-term control plan, and in summary, they will produce great synergy between all the components of the multidisciplinary team. It should be considered the standard in the care of patients with breast cancer. Strengthens non-technical skills of the participants, based on the trust and mutual respect of the participants. And of course, pathologists play a major role in its operation. We need criterion, experience, a global look, and Professor Juan Rosay produced a lot of very intelligent advantage in our specialty. And one of his sentences is this: the pathologist being able to give accurate correct advice requires medical knowledge that sometimes transcends morphological skills. But we don't need to carry all the weight, all the responsibility like in the past. The multidisciplinary team help us. And repeat, the core of this team is conformed by the clinic, the specialists in imagines, and we, the pathologists. In search of solving more or less profound mysteries, finding the concordance that allows to treat on fair basis our patients. The original suggestions of therapeutic management is frequent change by the but an specialized multidisciplinary team in over 40%. The pathological interpretation change are high. And they promote changes in the management of the patient in over 8%. In the media, is very well recognized the importance of the pathological diagnosis in the management of the cancer patients, especially in breast cancer patients. This lady, a health counselor, recognized our role in this form. The most important person on your medical team is someone you will probably never meet, your pathologist. The surgeon and oncologist will base many of their therapeutic decisions on the information provided by the pathologist. But at the same time, she remarks, so your life depends on the accuracy of the pathological report. How do you know if this is correct? Do you need a second opinion on your biopsy? In the media, it's very frequently to find reference about the importance of the second opinion. And the legal problem is another edge. Fortunately, our peers have worked a lot to objectify the real theme, putting in an objective and real dimension the problem. All of the above goes to the benefit of the best management in each patient. The tissue pathological diagnosis determines the surgical management and the eventual use of complementary therapies. The increase in the incidence of breast cancer, especially carcinoma in situ, due to increased imaging studies, has increased needle biopsy of small and atypical lesions. Reliability in pathological diagnosis allows ensuring correct decision making. In our work, the material was from 2012 to 2019. The great majority of the specimens were biopsy, core needle biopsy, 150. And the great majority of the material we received were slides and inclusions. Only one cytology and 76 immunohistochemistry of prognostic predictive factors. We classified the cases in benign and malignant. In the benign group, we included atypical and borderline lesions. In malignant, we included intraductal carcinomas, intraepithelial neoplasms with microinvasion, and invasive carcinomas. We considered major morphological disagreements when we change benign to malignant or vice versa. When we change intraepithelial neoplasm to carcinoma with microinvasion. Intraductal carcinomas to invasive carcinomas, or invasive carcinomas to intraductal carcinomas. Major discrepancies in interpretation of immunohistochemistry of prognostic predictive factors in hormone receptor when we change from positive to negative or vice versa, or when we found differences.
Excuse me. I'm sorry to interrupt. Could you please share your slides? Is that possible? You can go to the line at the top of your screen, and there you see share.
Now it's okay.
No, it's a green icon. Here I see it. It's a green icon at the bottom of your screen, and then you can share your screen.
I put in the green bottom. Excuse me.
Has your screen a green border?
Yes, yes. Oh, so sorry.
It's all right. We'll manage that.
Excuse me. Can continue without the share screen? I really so sorry.
Well, anyway, if it's impossible, just continue. At the beginning, I wasn't sure whether there are any slides, but just go further on, please.
I previously shared with the organization my presentation. Excuse me, but now I can't to share the presentation. I don't know the reason.
Okay. No matter. Just go ahead. We can follow you.
Okay. I told about major discrepancies in hormone receptors when we changed positive to negative results or vice versa, or when we found differences greater than 50% in the score. In HER2, when we changed from positive to negative or equivocal, or the negative, or from negative to positive or equivocal, or from equivocal to positive or negative. And in KI 76, when a score less than 20% was changed to 20% or more, or when the score differences were greater than 30%. Our results and diagnostic difference over 15%, but major discrepancies we found in 11%. In histopathology findings, features, about 5%, and in immunos interpretation, almost 30%. In the diagnostic change, in 5 opportunities, we change benign to malignant. 2 cases from ADH to DCIS. In 1 opportunity, papillary complex lesion to DCIS. Microtubular. No pude compartir las imágenes. ¿Dónde está la reunión? Aquí. Ya, póngala ahí. Y le puse ahí. No, no me dio la pata. Está abierto esto. Es que aprieta ahí. Ah, no importa. Excuse me. From papillary complex lesions to DCIS, from microtubular proliferation to ductal invasive carcinoma, and from lobular intraepithelial neoplasia grade 2 to the same diagnosis but with microinvasion. We change diagnosis from malignant to benign in 3 opportunities: DCIS to ADH in 2 cases, and DCIS to ductal proliferation, not ADH. And in 1 case, we downgrade the diagnosis from ductal invasive carcinoma to ductal intraductal carcinoma. Major divergences in interpretation of immunohistochemistry in hormone receptor was in 8 opportunities. We change negative to positive in 6 cases and positive to negative in 2 cases. In HER2 in 5 opportunities. From negative to equivocal, 3 cases. Equivocal to negative, 1 case. Equivocal to positive, 1 case. In KI, 76 in 5 cases. Score changes of less than 20% to 20 or more percent, 5 cases. The difference was in 7 cases. And a score difference greater than 30% in 2 cases. Discussion. The specialized review service has quality control in surgical pathology. Most pathologists correctly diagnose 80 to 90% of cases. Classification into large categories, for example, benign versus malignant, has good inter-observer agreement. This is valid for breast pathology when included within the benign lesions, the atypical borderline. The diagnostic variation between the external reports and those of our team is within expectations, both in histopathology and immunohistochemistry determinations. The multidisciplinary study of clinicians, imaging specialists, and pathologists with the knowledge of what the second opinion can contribute makes the management of these patients safer. In my almost last slide, sorry for not sharing in direct form, I put some historical articles one of Beers from 1979 with almost 11 of cases diagnosed as invasive carcinomas were not. 4 different articles up from 1995. Sales 2008 and Marco 2014 mention that error between 0.25 and 16%, on average about 8%. The errors, the mistakes are greater in borderline lesions, DCIAs with microinvasion, and lobular neoplasms. And Snish from the MD Anderson, Sales and Elston mention that well-defined criteria and focus workshops reduce reproducibility failures. Joint work of the multidisciplinary team with high confidence in its members give our patients the best chances to face their future. Thank you so much for your attention. The best and warm greetings from Chile. Please see our images from the platform of the meeting in the next futures. Thank you so much.
Muchas gracias, Dr. Alvaro. I think this was a very comprehensive presentation. Tenemos imaginación, as we in Germany say. I think we can imagine a lot of the points you mentioned. So, and I'm pretty sure it will be possible to have your slides available on the conference platform, and this makes it possible to review some special issues if needed. Are there any questions about Dr. Alvaro's presentation? So, if I may ask a question, how many specimens of breast carcinoma do you see in a usual year, for example?
About 150 to 200.
Is this biopsy and resection specimen, or biopsy and resection specimen together?
Surgical resections, but we see a lot of material from another patients, from core biopsy made in our hospital, because the high quality of the specialist in this imagine, and many patients continue the treatment in the public hospitals with public secure in health.
Oh, very well. Any other questions regarding the topics Dr. Varro outlined? Okay, very well then. So we go ahead and schedule, and I would like to introduce our next speaker. Now we go back to India. It's Dr. Manali Satisa.
Yes, good evening, everyone. I hope you can hear me.
Yes, we can hear you, we can see you, and we are curious about your presentation slides.
Okay, I'll start sharing my content. Okay, can you see the slides?
Yes, perfect. Thank you.
Okay, this is Dr. Manali from PGI Rohtak, India. I'll be presenting today about immunophenotypic analysis of non-Hodgkin's lymphomas. And this is a flow cytometric analysis at a tertiary healthcare center. Okay, so this is just the background. As we all know, the current WHO classification, it states that all the non-Hodgkin lymphomas, they cannot be classified on the basis of morphology alone and should be supplemented by ancillary studies that can be done by flow cytometry, immunohistochemistry, and molecular studies that includes cytogenetics, NGS, fission, etc. Okay, so to start with, what are non-Hodgkin lymphomas? They are just a heterogeneous group of chronic lymphoproliferative disorders originating in either B cell, T cell, or NK cell lymphocytes characterized by abnormal proliferation of monoclonal lymphocytes in the peripheral blood, bone marrow, lymph node, or any other lymphoid tissue. And as we all know, they represent one of the major health problems and they are of concern. So we need to study them in pretty detail. So these are the most common B-cell non-Hodgkin lymphomas that we come across in our region. They are CLL. The CLL is the most common NHL we come across in India, followed by prolymphocytic leukemia, follicular DLBCL, mantle cell lymphoma, hairy cell leukemia, marginal zone lymphomas, and other extranodal lymphomas. Followed by other common T cell and NK cell lymphomas. These are T cell prolymphocytic, large granular lymphocytic leukemia, CLPDs of NK cells, and others that you can see in the updated 2016 WHO classification for non-Hodgkin lymphomas. I'll not go in detail about the classification. So how do we proceed to a patient for the NHL? Okay, so in any case of NHL, we start with the clinical examination and lymph node FNAC followed by lymph node biopsy. But there is a requirement for the examination of bone marrow biopsy. Why? Because it's an important part for the staging procedure. If a patient is presenting with the bone marrow involvement, the patient is having stage 4 disease. Okay, so the bone marrow, the alone morphological evaluation for bone marrow to assess the involvement in lymphoid malignancy can be problematic at times because the morphologic alone cannot subtype all the subtypes of lymphomas. Also, it can be a painful procedure for the patient. A lot of patients here are non-compliant. It's a painful procedure, so they do not provide a consent usually for that. So why do we need, so here comes the role of immunophenotypic studies in the diagnostic pathologies that can be done by flow cytometry, that can be done on peripheral blood or bone marrow aspirate. And the second is IHC, immunohistochemistry, which has allowed a more precise diagnosis and characterization of these disorders. Okay, so what is the role of flow cytometry? It is a diagnostic test that provides a rapid diagnosis and faster results. We usually get results within 4 to 5 hours, and then we can hand over the report to the patient. It analyzes broader array of antigens with a quick multi-parametric analysis of large number of cells. It allows detection of expression of 2 or 3 antigens on the same cell at the same time. Okay, so keeping in view these advantages of flow cytometry, our aim and objectives of the study were to study the IPT profile of non-Hodgkin lymphomas by flow cytometry in peripheral blood and bone marrow, and form a minimum primary cost-effective panel for diagnosing NHL. Because in India, as we all know, everybody is not enough financially stable to provide to perform a highly very costly test like ancillary studies, including molecular study. Every patient cannot afford it, so we need to form a primary panel. As flow cytometry, it's also a little expensive test. So we need to form a minimum primary cost-effective panel that can be used for diagnosing NHL, followed by further subtyping of the cases based on IPT profile that is used in WHO classification. Okay, so this was a prospective observational study conducted on 30 cases of NHL in Pandit Bhagwat Dayal Institute. Okay, of Health Sciences, Rohtak, Haryana. The inclusion criteria, all the clinically suspected cases of NHL, either diagnosed by bone marrow aspirate, biopsy, or lymph node FNAC were used in the study. The exclusion criteria for the study was all the previously treated cases were excluded from the studies, and the precursor lymphoblastic lymphoma or leukemias, along with the bone marrow biopsy length with less than 1.5 centimeter. Okay, so peripheral blood and bone marrow aspirate was processed on flow cytometry. It was performed on an 8-color flow cytometer BD FSCS Canto 2. And the list mode data was acquired and analyzed by FSCS Diva software. The expression of all the gated events were plotted on the site scatter, SSC CD19 for B cells and SSC CD3 for T cells. Okay, this was the diagnostic panel of monoclonal antibodies that was used on flow cytometry. The primary panel comprised of CD3, 5, 7, 4, 8 for T cells, 19, 20, 23, 79, T, 200 for B cells, CD45 as common leukocyte antigen, CD56 for NK cell, and the secondary panel for further subtyping of the cases that included FMC7, CD25, CD123, CD103, and CD38 that was a marker that was used as a prognostic marker, basically in the cases of CLL. Okay, so this was the immunophenotypic diagnostic criteria that we used as a reference table for classification of the cases in our study. So all the cases, all the B-cell lymphomas. So I would like to mention all the cases in our study comprised of B-cell non-Hodgkin lymphomas only, because it was a limited period study that was around 1.5 year or 2 years, and included only 30 patients. So all the 30 patients were of B-cell lymphomas. So we will discuss about only B-cell lymphomas here. All the B-cell lymphomas, they are positive for 1920. And to start with CLL, it is basically CD5 positive, 23 positive, 200 positive, that is a classical marker for CLL these days, followed by dim positivity for CD59 and FMC7. Atypical CLL, all the same findings as above, except for the part it is negative for CD5. Okay, so third, mantle cell lymphoma, it has a classical expression of CD5 positivity and negative for CD23. And it is also negative for CD200. There are recent studies that says that CD200 can be used as a marker to differentiate between the cases of CLL and mantle cell lymphoma. The others were marginal zone lymphoma, hairy cell leukemia, follicular lymphoma, DLBCL, and few of the cases of non-Hodgkin lymphomas, they remain unclassified because they do not fit into any of these IPT criteria. You can refer this table for the classification of the cases. I'll not explain every single subtype here. Okay, to move on to our results. There was a distribution of the cases according to the age. The majority of the cases in our study were in the range of the age of 41 to 60 years of age. That is a very common age for non-Hodgkin lymphomas usually that we see. And the cases according to the gender, majority of the cases were males. Distribution of the cases according to the lymphocyte count. In the majority of the cases, the lymphocyte count was more than 5,000, the absolute lymphocyte count. I'm sorry, there is something with my presentation over here. That's some error. It's not able to, it's not clear over here. I'll share it with you later on. The clinical presentation of the cases, I'll tell you, the most of the patients presented with the presentation of fever, weakness, and lymphadenopathy. And the distribution of the cases, all the cases presenting clinically with NHL symptoms and any finding on FNAC or lymph node biopsy will further proceeded for bone marrow aspiration examination, and all the bone marrow aspirates and peripheral blood of those patients were subjected on flow cytometry. So after the flow cytometric examination, all the cases were divided into a broader subgroup, including CLL and non-CLL group. So why CLL and non-CLL group? First of all, it's very important to differentiate CLL and non-CLL group because all the patients of CLL, they do not require treatment usually. Here, the patients of CLL, until and unless presenting with symptoms, they are kept on follow-up for very long periods. Okay, so it is very important to differentiate between both of them. And the other part, to differentiate between CLL and non-CLL group, we just required a minimum basic primary panel that can be very cost effective at our and money saving for the patient as well. Because for the classification of differentiating between CLL and non-CLL will require just a B cell marker, CD5, 23, and CD200. Okay, that's it. So the CLL group in our study comprised of CLL along with a single case of atypical CLL, and the remaining non-CLL cases were further subclassified in using an extended panel into mantle cell lymphoma, marginal zone, and hairy cell leukemia. Okay, distribution of the cases on the flow cytometry. This was the distribution. CLL, majority of the cases on flow cytometry comprised of CLL, and this was the immunophenotypic expression of the CLL cases in our study. Positive for 1920, characteristic presentation, classical, CD23, 5 positive, 200 positive. And all the cases in our study were positive for CD38, negative for FMC7, CD10. They were either kappa positive or either lambda positive. Atypical CLL, as I already discussed earlier, it was positive for all CLL markers except the part for CD5 and CD10, which was negative. Moving on to mantle cell lymphoma, that was the second most common finding after CLL that we observed in our study. It was a classical present immunophenotypic expression, CD5 positive, 23 negative, and 200 negative. Okay, hairy cell leukemia. Hairy cell leukemia, it was positive for the B cell marker 1920, 79. It was also positive for CD200, while the other hairy cell leukemia markers like CD25, CD103, and CD123 were strongly positive, and all these 3 hairy cell leukemia markers were negative in all the other cases. Marginal zone lymphoma, it was considered as a diagnosis of exclusion because it was just CD23 positive, 79 positive, while negative for 5, 10, and 200. And the few of the cases, 10 to 12 cases in our study, remained unclassified, that we were not able to fit into any of the above subtype. And the expression was, they were positive for 19, 20, 23, 5, FMC7, every single marker, but they were negative for hairy cell leukemia markers, as well as they were negative for CD200. So the unclassified cases in our study, these unclassified cases were further subjected for bone marrow biopsy examination, followed by immunohistochemical analysis for further confirmation, just to cross-check what was the drawback that the flow cytometry could not evaluate these cases. So we were able to find that due to the lack of morphological assessment, because to look for a few cases like diffuse large B-cell lymphomas, you need a morphological assessment always. Okay, so due to lack of morphological assessment and non-availability of few confirmatory markers, I'll tell you later on, few of the cases remain undiagnosed on flow cytometry. So immunohistochemical analysis on all those cases, we were further able to classify 5 of those cases into 3 into follicular lymphoma and 2 into diffuse large B-cell lymphoma. So it was seen that the morphology plays an important part too in the classification of lymphomas. And as well as 2 of the markers like BCL2 and BCL6 that were required. BCL2 positivity was seen in all 3 cases of follicular lymphoma, and BCL6 in DLBCL. So they were not available on flow cytometry. Hence, the IHC was required. Okay, after using IHC, after flow cytometry, agreement between the diagnosis was seen between both the studies to see the accuracy of immunophenotypic findings. So it was seen the percentage agreement between flow cytometry and IHC was highest among the cases of CLL. It was 83.3%, followed by mantle cell lymphomas and unclassified cases. There was no agreement seen for atypical CLL, marginal zone, hairy cell leukemia, follicular lymphoma, and DLBCL, since these cases were exclusively either diagnosed on flow cytometry or on IHC. As I already told you, the follicular lymphoma and DLBCL, both of these lymphomas were not diagnosed on flow cytometry. So there was no percentage agreement counted between these two. Okay. So next, all the markers that we used in flow cytometry and IHC, there was percentage of agreement seen and kappa statistics were applied. Okay, so there was absolute agreement between flow and IHC for all these markers, 19, 20, 30, 3, 7, 4, 8, 56, and 45. Why? Because all these markers were either positive or negative, both on flow cytometry and IHC. So we could not apply kappa statistics over here. And the no p-value was calculated for these. But there were few markers that showed discrepancy on flow and IHC. So agreement of the markers for these kappa statistics were applied for these markers, CD23, CD79, CD5, and CD10. And it was seen that the concordance rate between flow and IHC was highest, 100% for CD10, and followed by CD23 and CD79 and 5, with all of them showing p-value less than 0.05. So taking IHC as the gold standard test, kappa statistics were applied and concordance rate for every marker was calculated between flow cytometry and IHC. And the concordant markers, as I already told you, were CD23, 79, 5, and 10. with the statistically significant results for 5, 23, and 10 with a p-value of less than 0.05. Okay, so but after these broader analysis, there were few limitations in our study. The sample size was very limited, as only 30 cases of NHL were included in our study. Because our study included only stage 4 NHL cases, and usually the patients with NHL having stage 4 disease, they usually do not survive to a very later stages. And second drawback was lack of morphological assessment. Few of the NHLs required morphological assessment in very detail, like follicular lymphomas and diffuse large B-cell lymphomas, also hairy cell leukemia cases. There was no availability of BCL2, BCL6 on flow cytometry, and therefore no case of follicular lymphoma or DLBCL was diagnosed on flow cytometry. So why did we perform this study? Because lymphoma, it is one of the major health concern all over the world, and it is increasing day by day. It is a common malignancy affecting both children and adults and increasing rapidly. And our modern pathology, it relies on immunophenotyping for accurate classification of lymphomas. And as we already said, the WHO also suggests that the classification of lymphomas should not be done entirely on IPT or entirely on morphology. It should be a combined approach. It should be on the basis of morphology along with supplementation with IPT. So here in study, we evaluated the immunophenotyping of various B-cell lymphomas by flow cytometry, and those findings were further confirmed by immunohistochemical analysis. And using IHC as the gold standard test, appropriate stats and kappa statistics were applied. Okay, as already discussed, there was no statistics applied on the markers 19, 20, 3, 7, 4, 8. And correlation was found for the comparable markers like 5, 23, 79, CD10, kappa, and lambda. And the agreement between various comparable markers ranged between 76 to 100%, similar to studies done by Dewan K. et al. And Bismier KW et al., who also observed a concordance rate between flow cytometry and IHC for the further above comparable markers, and the rates were 80 to 100% and 76 to 100% respectively. Okay, after the individual, the CD markers, there was a few little bit discrepancy about the monoclonality assessment, like kappa and lambda assessment. Because immunohistochemistry, all the cases were further subjected for kappa and lambda staining on IHC, and it was found that IHC was a very non-specific way to assess the clonality of the cases, because it shows a lot of background staining. In 30 cases, 15 of the cases showed lots of background staining. So we were not able to classify them as kappa positive or either lambda positive. While on the other side, flow cytometry was a better method for the assessment of clonality, because all the 30 cases, they were either kappa positive or lambda positive. So monoclonality assessment was very easy on flow cytometry, while it was not on IHC. So can we conclude that, here's the conclusion, can we say that IHC is a better tool for subtyping of NHL cases, while flow cytometry was found more sensitive in assessment of monoclonality? We can say this or not, even I don't know, because in our study, the sample size was very limited. So we need further studies to pass a statement for this. But here we can approach a two-tier approach for immunophenotypic analysis in all the newly diagnosed cases, using a minimum primary panel that can be cost effective, including the markers as 19, 25, 23, 79, 10, 45, kappa, and lambda. Because using just these markers, we can separate CLL cases from non-CLL cases. So at least we can say that the patient with CLL, because it's very important to differentiate between both of them, because the patients with CLL, they usually do not require treatment and can be kept on follow-up. And the remaining non-CLL cases, they can be further subjected to an extended panel. It can be applied for further subtyping of the cases. So these are the references I used for in our study. You can see them later on. So this was my presentation. Thank you so much for listening and paying your attention. Any doubts or queries?
Well, Dr. Melanogenesis, thank you very much for this very illustrative and comprehensive analysis. Are there any questions from the audience? Well, I've got a question. Do you have experience in application of flow cytometry on cytology samples?
Yes. There is a separate study that we have done on FNAC of all the NHL cases, and the FNAC sample was processed on flow cytometry for all the cases. There is a separate study done in our institute 2 years ago.
And do you have any technical difficulties in performing the flow cytometry on the FNA specimen?
Yes, initially we had, but even I don't know exactly in detail. That's a technical part on the technician aspect, but there is something with the diluting factor that we use now, and a filter that the company has given us recently. So initially we faced some technical difficulties with the cell content of the sample, but right now it's a very smooth process.
Thank you. Very good answer to this, because flow cytometry is a diagnostic tool that can be used in cytology.
Yes, and it even the bone marrow aspirates even on bone marrow aspirates we faced some technical difficulties initially because of the bone marrow clot, and the cellular content was very high on the bone marrow, and even we get fat particles as well on bone marrow aspirates. But that's a technical part that was being solved at a company level, so we do not face any technical difficulties right now.
Thank you.
Okay.
Any more questions? Okay, very well then. So then I'm very happy to introduce our next speaker. This will be Dr. Arnav Kumar Ruchaduri. I hope the pronunciation is okay. And please go on and show us your slides.
Very good evening to everyone. I will be sharing my slides. The topic for my today's presentation is spectrum of histopathological lesions of oral cavity in a tertiary care hospital in the Malwa belt, that is our region, with special emphasis to oral squamous cell carcinomas. Introduction. India is the third largest producer of tobacco worldwide and ranks second in consumption according to the Global Adult Tobacco Survey report, with Punjab being ranking among the least common user of tobacco. Tobacco chewing in any form has been associated with pathological lesions, both benign as well as malignant. The majority of oral cavity lesions are benign, with commonest being mucus retention cyst, leukoplakia, and inflammatory conditions. Oral malignancy represents the third most common form of malignancy in the developing countries. Amongst the neoplastic lesions, squamous cell carcinoma was the most common pathology that we saw here. Squamous cell carcinoma constituted 80 to 90% of all the malignant lesions of the oral cavity. Different sites of the oral cavity have different propensity for different types of lesion. The present study was conducted to study the spectrum of oral cavity lesions. Coming to materials and method, a prospective study of 322 specimens were studied in the Department of Pathology over a period of 1 year. Specimens were received in 10% formalin in the Department of Histopathology of Adesh University from Department of ENT and Dental Surgery. After standardized processing into paraffin-embedded sections, hematoxylin and eosin stained slides were prepared for diagnosis under the light microscopy. Results of the 322 cases studied, non-neoplastic lesions constituted the major bulk with 60.8%, while neoplastic lesions constituted 36% of all the cases. Among the neoplastic lesions, benign lesions constituted 51%, while malignant neoplasm represented 48.2% of all the neoplastic lesions, with benign to malignant ratio of 1.07:1. And the age ranged between 5 years to 85 years, with a mean age of 47 years. Male constituted the majority, around 60%, while female comprised of 37.2%, with male is to female ratio of 1.6:1. While it significantly changed in cases of malignancy, it became 2.7:1. Tongue was the most commonly affected site, constituting 154 cases, that is around 49% of all the cases, followed by buccal mucosa 17.7%, lip 16.4%, and minor salivary glands 4.8%. This table shows the different distribution of the site-wise distribution of the oral cavity lesions, with tongue being most common, followed by buccal mucosa, lip, and minor salivary glands, and floor of mouth. Histopathologically, mucus retention cyst was the most common non-neoplastic lesion, comprising of 37.2%, followed by leukoplakia around 31%. Among the benign neoplastic lesions, squamous papilloma was most common, comprising of 43 cases, thereby constituting 71% of all the benign neoplastic lesions. Among the malignant neoplastic lesions, squamous cell carcinoma was the most common, amounting to 75% of all the malignant oral cavity lesions. Poorly differentiated squamous cell carcinoma was most common, with the histological grading constituting 45% of all the SCCs, followed by moderately differentiated 33.3%, and well differentiated only 21.4%. The details are being given in the next tables. Here we can see the most common is mucus retention cyst, 73 cases, followed by leukoplakia 61 and dysplasia 16. Here we have divided this table into benign neoplasms and malignant neoplasms. In the benign, the total number was 60, and this picture shows the squamous cell carcinoma poorly differentiated variant with bizarre hyperchromatic neoplastic squamous cells having high grade of nuclear pleomorphism. This is the slide of the well-differentiated squamous cell carcinoma showing well-formed keratin pearls. This is the case of mucoepidermoid carcinoma that we saw in the minor salivary glands, showing the squamoid cells along with foamy cells and mucin pools. This is the Elchin blue slide, 100x magnification. This is also the mucoepidermoid showing the squamoid cells. This is the PLGA 3 cases we found in the minor salivary glands, showing the well-circumscribed infiltrating tumor infiltrating into the residual salivary gland tissue and the connective tissues. This slide shows a case of ameloblastoma exhibiting the basaloid follicular appearance with central portion composed of loose stellate reticulum. Coming to discussion, this prospective study was done to assess the distribution of oral cavity lesions among the biopsy specimens. The oral cavity includes the lip, hard palate, lower alveolar ridge anterior two-thirds of the tongue, sublingual regions, and various parts, the retromolar trigone, and the oropharynx and nasopharynx. According to the Cancer Statistics 2020, a report from the National Cancer Registry Program in India, lip and oral cavity cancer have been ranked 12th most common cancer in Asia and ranked 8th among all the cancer in men, with an estimated cases of around 190,000 in this year. The standard incidence rate in Asia is 3.8, and an estimated of 97,000 deaths have already occurred in Asia due to lip and oral cavity cancers, with the age standardized mortality rate of 2.2. It is the second most common cancer among men in Southeast Asia and Central Asia, with an age standardized incidence of 9.9 and 5-year prevalence of 12.1%. The eastern and the western part of the Asia have low incidence rates. Oral lesions have caused a wide range of factors such as aging, trauma, infection, neoplasia, systemic diseases, chemical and thermal agents, and especially eating habits such as tobacco, betel nut, and alcohol. These includes a variety of lesions comprising of benign lesions such as papillomas, retention cysts, pre-malignant conditions, leukoplakia, malignant lesions, as well as oral squamous cell carcinomas and minor salivary gland tumors. In our study, the age ranged from 5 to 85 years. This was in concordance with the studies conducted elsewhere also. In our study, the oral mucosal lesions were more frequently seen in females, which was similar to this study. We also found that the malignant lesions were more common in males with a male to female ratio of 2.7:1. The peak incidence of malignant lesions were seen in the age group of 5th decade, followed by the 7th decade. Only a single case was seen in young patient. In our study, the benign neoplastic lesions accounted for 60 cases, that is 51.7%, while malignant was 48.2%. Malignant neoplastic lesions were more common in males. According to the site of development of the oral cavity lesions, the most common site was tongue and squamous cell carcinomas amounting to 57.1%. The cases confirmed as squamous cell carcinoma were further graded according to the Anaroth grading system, Broders and Brines, from well-differentiated to undifferentiated tumors according to the Anaroth grading system. AC Broder initiated the first quantitative grading system of the cancer of lip. It was suggested that the tumor be graded according to the differentiation of the tumor cells and their keratinization. Then Broder graded it into 4 grades, grade 1, 2, 3, 4. 1 was well differentiated with 75 to 100% cells differentiated. Grade 2 was moderately differentiated with 50 to 75% of the cells differentiated, and grade 3 was poorly differentiated with only 25 to 50% differentiation, and grade 4 was anaplastic less than 25%. Our study showed squamous cell carcinoma present in grade 1 and 2 and 3, but there were no cases of grade 4, that is, there was no anaplastic grade. Next came the Jacobson multifactorial grading system that was based on the structure, differentiation, nuclear pleomorphism, mitosis, and staging of invasion based on this grading system. Again, Anaroth in 1987 used a new grading system based on the 3 parameters: nuclear pleomorphism, keratinization, and mitotic figures for the oral SCCs. The sum of all the scores were again grouped into 3 grades: grade 1, 2, and 3, with grade 1 having 6 to 12 score, grade 2 13 to 18 score, and grade 3 19 to 24 score. The results were then compared in the metastasizing and non-metastasizing groups. In 1992, Brine proposed a new deep invasive cell grading system based on the nuclear pleomorphism and keratinization based on the Anaroth grading system. The number of mitosis and the stage of invasion was not used in the previous studies. Only the cells at the invasive margin of the tumor were graded. Again, the total sum of the scores were grouped as grade 1, 2, and 3. The results were again compared. Around 25 to 50% of the schwannomas occurring in the head and neck, with only 1% occurring in the oral cavity, most commonly seen in the tongue. Other sites of intraoral schwannomas are the hard palate, buccal mucosa, and lip. Our study included 2 cases of schwannoma, one occurring in the buccal mucosa and the second one occurring in the lower lip. Histopathologically, the tumor tissues were encapsulated and comprised of typical Antony A and Antony B areas. Coming to conclusion, from the present study, it was observed that the majority of the oral cavity lesions were benign in nature. However, malignant lesions were reported with greater frequency. In this belt, actually this area is a malignant belt because of the excessive use of the fertilizers, and because of this reason only we have conducted this study. Any mass lesion occurring in the oral cavity should be biopsied to rule out malignancy. Some mucosal fibrosis was observed in the younger age group, which is a known pre-malignant feature. Tuberculosis of the vestibule as a primary lesion is very rare, and schwannoma of the hard palate is also rare. and better efforts for increasing the awareness among the mass regarding the harmful effects of tobacco should be exercised. In our cases, we took history from the patient as well as the patient parties, but the main difficulty that we faced that the patients were all farmers and they were not so much educated, so they couldn't give us the whole history regarding their eating habits and their smoking habits, but most of them were non-smokers. None of our case had any special risk factor or any habit. It was consistent with the previous studies, whereby no major risk factor, smoking or drinking were present. The ability to control oral cavity malignancies depends on two cornerstones. One is your prevention, and the second being early diagnosis. Continuing educational campaigns are needed on the local, state, and national level in order to educate the public about the risk factors and the early signs and symptoms associated with these diseases. Individuals also need to be encouraged to seek regular professional oral examinations by a dentist or a physician. Finally, the healthcare workers must be encouraged to perform oral cavity examination as part of their regular regime and to be knowledgeable about the early signs of benign, premalignant, as well as malignant lesions of oral cavity. These are the references.
So thank you.
Thank you, sir.
For this very interesting and very fast presentation. However, very impressive and very impressive data. Are there any questions from the audience? Well, if there are no questions, I've got one question. Did you evaluate the P16 or HPV status in your oral cancer lesions?
So we took the HPV status of the patients, but P16 we couldn't do actually because all the farmers are not so financially stable, no, sir. The main thing is that because they use nitrate-based fertilizers, so we conducted this study based on that fertilizer thing only, because in our area, this is the main wheat producing area of India, Punjab. So the fertilizer uses is very excessive here, and mainly nitrate-based fertilizers are used, and the water content also has some amount of arsenic in it. So we are continuing this study. So we want to just rule out whether it is because of the fertilizer-based oral malignancies, or are these effects of heavy metal poisoning due to the prolonged use of these fertilizers.
Oh, thank you for this very interesting and very important factor, because this is a very supportive local specialty, and it's very interesting to hear from this the special things you have to keep in mind when you analyze your patients' collective. Are there any? Very well. We have another question. Were there any basaloid tumors in the study? Dr. Sophia is asking.
No, I didn't find any basaloid tumors actually.
Okay. Any other remarks, comments, questions?
Actually, I would just like to enhance on the basaloid tumor question. I was part of a study which dealt with a lot of basaloid tumors in the head of neck and base of tongue. And unfortunately, at that time, the role of P16 was not very, as we know, we have constraints in India to do the role of P16 in immunohistochemistry. But I think the characteristic histomorphology of these tumors can help. So I was just curious to know if Dr. Arnav had seen any of these tumors, especially in the rare areas that he mentioned in the arytenoid and in the base of the tongue.
No, ma'am. Actually, we didn't find any basaloid tumors, but we are conducting another separate study focusing on the minor salivary glands. So if I find anything, I'll just let you know, ma'am.
Thank you so much. Very, very good data that you have. Thank you.
Thank you.
Yeah, well, very well presentation and very interesting discussion. So if there aren't any more questions, we see our final speaker, who is just in the trenches. And yeah, well, and so I would like to welcome our last speaker. This is Dr. Abhishek Gupta. And yeah, please go on with the presentation. We are happy to have you here as the final speaker. So we can see your presentation. The only thing that's missing is your voice.
Am I audible now?
Oh, perfect. Yes, we hear you loud and clear. And we also got a glimpse of your presentation. And yeah, if you like and you're ready, you can start.
Yeah. Good evening, everyone. I am Dr. Abhishek from the resident Department of Pathology from Himalayan Institute of Medical Sciences, Dehradun. And I studied the tumor-infiltrating lymphocytes and expression of programmed ligand 1 in carcinoma breast. Globally, breast carcinoma is the second most cancer in the world, with an estimated 2.08 million new cancer cases diagnosed in 2018. Globally, the incidence of breast cancer is 25.1%, with ASR of 46.3% per 100,000.
Excuse me, could you share your slides? We've got a glimpse of it. Could you again share your screen, please?
My screen is not sharing.
No, just when you started, we had it for a brief period of time. Now we see you, but it works. You just check it again, please. That looks good. Very well. Now we see your screen. PowerPoint is loading, and please go ahead.
Is it visible now?
Yes, perfect.
Okay. Globally, the breast cancer is the second most cancer in the worldwide, with an estimated 2.08 million new cancer cases diagnosed in 2018. Globally, the incidence of breast carcinoma is 25.1%, with ASR of 46.3% per 100,000 women. In India, the incidence is 27.7%, with ASR of 24.7 per 100,000 females, and the 5-year prevalence rate is 32.2%. Now coming to the prognostic factor of the breast carcinoma, it depends on the various factors such as age of the patient, pregnancy, use of OCPs, time of diagnosis of the carcinoma, site of the tumor, gross size of the tumor, morphological variant of the tumor, and the grade of the tumor. Moreover, tumor margin, tumor necrosis, elastotic factor, or any fibrotic focus, LVI, PNI, axillary lymph node mats, or TNM staging with surgical margin or recurrence of tumor also tells you the prognosis of the tumor. Besides these classical and the morphological factors, it has been observed that the crosstalks between the epithelial carcinoma cells and the stromal cells play an important role in the growth of various carcinoma. Now, what are these cells? These cells are the lymphocyte. So recently, the morphological evaluation of the tumor-infiltrating lymphocyte is also being studied in breast carcinoma. Reason being, an attempt is made to understand the role of TIL in determining the prognosis of the breast cancer. In addition to the prognosis, TIL also tells you about the treatment response of the carcinoma of breast. Now, my other marker of interest is PDL1. PD1 has two ligands, that is PDL1 and 2. What I have taken is PDL1. It is a pathway which is very important, which has very important role in adaptive immune response and its association with tumor, lymph node status, and the age. In addition to the B lymphocytes, monocytes, antigen-presenting cell, PDL1 has been found over the expressed over the epithelial cells, and its expression has been observed associated with poor prognosis in the pancreatic and renal cell carcinoma. So, our immune system works on the switch on or switch off basis. When the switch gets on, these tumor cells, that means these tumor cells are proliferating and they are secreting some cytokines, and they have a receptor which was recognized by the T cells, and these T cells are designed and they kill the tumor cells. But when the PD1 program that one acts on the T lymphocytes, the switch gets off. What it means, when this PD1 and PDL1 pathway completes, they inactivate this T lymphocyte, which now they can't be, now they are unable to kill the tumor cells. That means they are inactivated, they are in the inactive stage. So these pathways are area of interest. If we are able to recognize these PD1, PDL1 pathway with the help of immunohistochemistry, we can tell that these tumor cells have this pathway. So we can introduce a immunomodulatory therapy which prevents this pathway and the tumor cells from the for inactivating the T cells. So the expression of PDL1 has been recently studied in breast carcinoma and has shown variable results. Few studies have shown that PDL1 increased expression is associated with poor prognosis, especially in triple negative breast carcinoma, while in contrast, other studies have concluded that its expression is associated with lower risk of breast carcinoma death. So the present study was therefore undertaken with the hypothesis that increased expression of program that ligand 1 is associated with decreased tumor infiltrating lymphocyte. It was also hypothesized that tumor infiltrating lymphocyte and expression of PDL1 will also correlate with the various clinico-pathological factors of breast carcinoma. It may be further useful in determining the prognosis along with immunomodulatory therapy in breast carcinoma. Now, what are aims and objectives? My first aim is to, I've studied the tumor infiltrating lymphocyte in carcinoma breast. I studied in immunohistochemical expression of program that ligand 1 in carcinoma breast, and finally the last one is the association of PDL1 and TIL with clinico-pathological parameters. Now, our material method. This study was conducted in Department of Pathology, Himalayan Institute of Medical Sciences, Dehradun, for the duration of 12 months with a sample size of 50, and the type of study was cross-sectional and observational. When we received the specimen from the surgery department, first of all, the tissue is fixed in the 10% formalin overnight, and then grossing is processed on the next day according to the standard procedure. After the grossing, we cut the block in the thickness of 4 to 5 micron with the help of microtome, and the slides are stained by HNE. After the staining, we classify the breast carcinoma associated histomorphological feature grading, and TNM staging was done. The molecular status of the breast carcinoma was assessed by ER, PR, HER2/neu, and Ki67 according to the WHO. Now, the microscopic evaluation of TIL on HE stain sections are done according to the recommendation given by the International TIL Working Group 2014. First thing first, we have to define an area for the TIL evolution. There are certain criteria for this. The first criteria is we have to locate an area in which we are counting this TIL. It should be within the borders of the tumor. After that, we have to make sure that the edges should also be included within this area and should not be reported separately. The exclusion are the whatever the extratumoral DCIS or the adjacent normal tissue, it should not be included within the TIL evaluation. And the last one is we have to exclude out the areas of necrosis and fibrosis. Coming to the step 2, we have to focused on the stromal TIL. According to the TIL working group, they said only include the stromal area for the evaluation of the tumor infiltrating lymphocyte. But there are certain studies which include both stromal TIL as well as the epithelial, or I can say intratumoral TIL. I also include both stromal TIL as well as the intratumoral TIL. So we have to focused on the stromal TIL. Now, then we can see the slides on the low magnification, and we can see two things. Either the stroma is predominantly collagenous and only few lymphocytes or infiltrates are seen, or the stroma is rich in the lymphocytic infiltrate. Coming to the step 3, once we have focus on the area, we have to make sure that the infiltrate should be either lymphocyte or plasma cell. We should not include any granulocytes, that is neutrophil or eosinophil. Coming to the step 4, on the low magnification, we just assess the percentage of the TIS, stromal separately and epithelial separately. So after the assessment, we can grade them either mild, moderate, and severe. In the mild group, the tumor contain either no or minimal immune cells, and the percentage that we have given is 0 to 10. In the group B, it has the intermediate infiltrate, that is 10 to 40%, and in group C, they have the high immune infiltrate, that is above 40 to 90%. After the histopathological diagnosis, histochemical analysis for PDL1 was performed on the paraffin embedded formalin fixed biopsy sections as per the standard procedure and instruction given by the manufacturers. Now coming to the results. The mean age was 53.8 with the age range of 21 to 81 years of the patient. Upper outer quadrant was most commonly involved. Distribution of carcinoma breast according to the local examination. 18% of the patient shows PUD orange, while 8% show ulceration. 56% of the patients have hard lump, while the non-mobile lump was present in 32% of the patient. In non-mobile lump, the fixity to the skin was present in 20%, while the fixation for the underlying structure was present in 10% of the patient, and both skin and underlying structure were fixed in 2% of the patient. Axillary lymphadenopathy was present in 78% of the patient. Now, distribution of the carcinoma according to gross examination, the mean size was 4.55 with a range of 1.5 to 10 centimeter lump. Distribution according to the histopathological examination, the RB score of grade 2 was present in 74% of the patient. Intratumoral DCIS was present in 30. Extratumoral DCIS was present in 6% of the patient. Necrosis was severe, present in 12% of the patient. Calcification in the 6%. LVI was present in 82% of the patient. while the perineural invasion was present in 18% of the patient. Uninvolved breast showing the fibrocystic breast disease was present in 90% of the patient. Now, distribution of carcinoma breast according to TNM, the stage T2 was present in 60% of the patient. Distribution of the breast carcinoma according to lymph node metastasis. Mean lymph node mets was present in 12.10 patient and median was 6.67. Now, the association of stromal TIL with pathological T stage in breast carcinoma was present. So the p-value comes out is 0.015, and PDL1 association was present with the pathological end stage, and p-value is 0.037. However, the association of PDL1 with stromal TIL was not present, as the p-value is 0.288, and the association of PDL1 with epithelial TIL was significant. The p-value is 0.008. The association of the living status with various parameters are present. The p-value is less than 0.05, and it is present in the age, distance from the nearest margin, mitotic figure, pathological end stage, and ER, PR, and HER2/neu. Now, this photomicrograph shows this is the tumor and this is the stroma. So here the stroma is mostly fibrocollagenous and with very less TILs, that is lymphocytes. So we grade them in the mild category. In this, these are the lymphocytes which are present in the stroma, and we categorize in the moderate category. The third one, the stroma is rich in the lymphocyte, and so we categorize them in the severe, that is the more than 50% of the lymphocytes. Same is done with the epithelial TIL. Mild, moderate, and severe categories were done. Coming to the PDL1, the PDL1 grade 0 is this photomicrograph shows the grade 0 of the PDL1, grade 1 with this picture, and PDL1 grade 2, and this shows the PDL1 grade 3. Coming to the discussion, the breast cancer is the most frequent cancer of death in females of less developed region, constituting around 14.3% of the all cancer deaths. Worldwide, the mortality rate is 15%, while in India, it is 23.5%. In the present study, at the cutoff of less than 11%, stromal TIL specificity was 70.7%, sensitivity was 44.4%, and the negative predictive value for the living status is 85.3. Same study was done by Rowan et al. At a threshold of 20%, the stromal TIL sensitivity was 56.7%, specificity was 68.7%, and negative predictive value was 70.1%. The epithelial TIL cutoff at 1.8% observed is 66.7 sensitivity, 48.8 specificity, and 87% negative predictive value for predicting negative status of the cases. Similarly, it was found by the Rowan et al. That at a threshold of 10% epithelial TIL, sensitivity was 56.7%, specificity was 66.7%, and negative predictive value was 69.5%. The present study similarly concluded that PDL1 expression in tumor correlate with more aggressive tumor subtype, as it was statistically significant with pathological end stage. However, the statistical association with overall survival was not significant, which was concordant with the study done by the Botti et al. Coming to the conclusion, the stromal TIL was seen in maximum number of the cases of breast carcinoma, and PDL1 immunoexpression was also positive in maximum number of cases. However, no statistical significant difference was observed between stromal TIL and PDL1, although epithelial TIL and PDL1 immunoexpression shows a statistical significant difference. The maximum number of cases were of T2 stage, and most of them survived for the 6 months of diagnosis. This was the statistical significant difference between stromal TIL with size of the tumor and involvement of nipple and areola, although no association was observed between stromal TIL and difference parameter of the microscopic examination. PDL1 was positive in the cases with axillary lymph node metastasis. However, no association was observed between stromal TIL and PDL1 with gleaving or tumor recurrence in breast carcinoma. Further studies with larger number of cases and extended duration may be done to assess the association of stromal TIL and PDL1. Thank you.
Well, thank you, Dr. Abhishek Gupta, for this very interesting contribution. And I would like to ask the audience if they do have any remarks, questions, discussion points. So there's a question from Dr. Mona Dahal. Please
Yes.
go further on.
Thank you, Dr. Abhishek, for a wonderful presentation. I'm Dr. Mona Dahal, working as an assistant professor in Department of Pathology in Dharan, Nepal, in BPKHS, BP Kerala Institute of Health Sciences. I have just a small query. Like, you had graded the tumor-infiltrated lymphocytes in both stroma and the epithelium. So I just wanted to know, what was the grading criteria for what is the criteria for grading it as mild, moderate, and severe?
Ma'am, as I already told that the grading criteria is mild, moderate, and severe. Less than 10% is the mild. That means the lymphocytes that are present in the stroma are less than 10%. Then moderate, that is a 10 to 50%. When we are looking this the slide, we have to be and assess the percentage of the lymphocyte in the stroma only. So basically, when we assess, we grade them as moderate, and in the severe, the stroma is very rich in the lymphocyte, and we graded it as the severe. That is a high grade.
No, I just wanted to know, like, how was the grading done? Like, how did you calculate it as 10% or 11% or 25%? How was the percentage calculated? That was my question.
What we have done is we look at the slide and select an area. After selecting, we done in the 10 fields. After doing in the 10 fields, we divided by the 10 and the percentage come. Like in one field, I focus an area and it comes out 40. Then I go to the second field. In second field, it comes out 20. Then I go to the fourth field. In fourth field, it comes out to be 50 or anything. Then subsequently, I go to I calculate in the 10 fields. After calculating the 10 fields, I divided by the 10. And same is done by the other pathologist, Dr. Smita Chandra. And after that, as we did it separately, then we take the mean of both of us results.
Okay, thank you so much, Dr. Abhishek. That was from my side. Thank you.
More questions? Well, I've got a question. I would like to know which antibody do you use for the PDL1?
It is an antibody, sir. PDL1 is itself an antibody. Program that ligand 1.
Yeah, I know, but there are different clones you can use for the immunochemistry.
Different clones, sir. That I don't know, sir.
Okay, well, so there are 5 different commercial antibodies that can detect PD-L1, and it's quite interesting because the departments around the world use different antibodies, but they are basically comparable, and therefore it would just be interesting to know which clone from which company you use. So, but if you don't know, it's okay. So, any further questions? Maybe also to the previous presentation, something you have in mind you'd like to discuss, something you point out or like to comment?
Actually, sir, right now I am in a COVID duty, so I am unable to see any of the presentation.
Oh, very good question. Very, very good question. So we can announce that all of the presentations are recorded and they will be uploaded on YouTube on or before December the 7th. So you can review your own presentation and you can review all the presentation of today and of course all the presentations of tomorrow. And in addition to that, some of the videos will also be uploaded to the Utilitarian Conference website. So there will be plenty of opportunities to share and review some of those sessions. Well, so if there aren't any more questions and any more comments, I would like to close this session, but not without saying again, thank you to all those impressive and inspiring presentation. And I'm very happy that we performed this first day of the conference so well, and that it was possible that we come together from all the places in the world. And this is a moving moment, and I'm very glad to share those moment of pathological community with you. So for this day, again, thank you, Dr. Imara, Dr. Ashana, Dr. Kirk, Dr. Inessa, Dr. Alvaro, Dr. Manali, Dr. Arnav, and Dr. Abhishek. We will continue tomorrow, and we will start at the same time we started today. It will be 9:30 a.m. London time. So again, 9:30 a.m. London time. And we will continue with the second day of this online congress. So
thank you so much, sir.
So when there's nothing more left to say, I will say goodbye to you, and I hope to see you all tomorrow with also interesting and inspiring sessions.
Definitely.
Have a good night and see you tomorrow.
Bye-bye.